In my language, there's a saying that there's one bad thing that happens for good things to happen. Charles Emisa has died, a very bad thing. But would that lead to the coming of good things? That is our hope and aspiration. And that is one of the key conversations we'll be having on the big issue today. Because a committee has come out and told us that there was pure case of negligence along the line, both by doctors and by nurses. People who you can trust your life with, watch your life to go away. Would we say never again? And would this be the last time we ever hear such a situation? That is one of the conversations we'll be having here. You're welcome to The Big Issue on 97.3 City FM and on Channel 1 Television. I am Umaru Sandamadu. I introduce the topics and the guests after this break. You're welcome.
Watching DSTV means getting the TV you love, but staying connected means getting something extra. Stunning. Extra matches, extra dramas, the best local and the world's biggest. Extra laughter, music, movies, and extra vim.
I love it.
Just stay connected or reconnect and get upgraded to the next higher package at no extra cost. Charlie, we got you. Keep watching. Get more with DSTV.
Hello and welcome to the Channel 1 newsroom from our studios at number 5, Ola Hansen Lane at Tesano in Accra. I am Nanatifu Obwati.
I'm Frema Edunyami.
I am Umaru Sandamadu.
I am Inosafo.
I am Charles Ozukumi.
I am Akosia Otrick.
They've given you land to build an airport, and the airport is named after them, and then you are going to change it and put your name.
We hear a Jumara National Apprenticeship Program in Kokon Kete. Well, they are paper.
A terrorist attack in Burkina Faso claimed the lives of 8 Ghanaian tomato traders.
Our fire extinguishers, they are empty. In the market, our fire extinguishers are empty.
This is a bill Ghanaians have been working for. It was one of our flagship strategies for economic transformation.
What do we have to do now for you to call off the strike?
The others also, did influence the voters.
Prof, what becomes of these students, especially the continuing ones?
They should reverse everything that they have done.
Channel 1 Newsroom airs Monday to Sunday at 8 p.m. only on Channel 1 TV.
Welcome to The Point of View. This is your favorite current affairs show here on Channel 1 Television. On The Point of View, we pick the right topics, get the right guests, and ask them relevant questions on issues that matter to you.
With the complexities of the issues happening around us on a daily basis, it's the hard-hitting conversations and the probing questions of The Point of View.
So what is the Public Account Committee's job?
So what we do is to scrutinize, clarify, and find out why certain infractions have been made.
What do these IMF programs try to do?
The current program is for budget support.
Okay.
There are no projects attached.
That teases apart the twisted entanglements of politics and governance, as well as religious and social discourse. The Point of View brings you the policymakers and duty bearers and drills down to the very bottom of issue.
What authority do you have?
The Point of View airs every Monday and Wednesday at 9 p.m. only on Channel 1 TV. In a world filled with challenges, we all need guidance, hope, and a lifeline to anchor us.
This is Lifeline, and I'm your host, Fred Crunchy Mensa.
From social issues, relationship challenges, and family matters, Lifeline is here to inspire, uplift, and guide you on your journey.
Where we give you support, where we hold your hand through the valley and through.
This Sunday, we continue our conversation with Samuel Koku Anyidaho on the Upside Down Show for a candid conversation featuring the Mills Institute.
In fact, when he passed, a lot of propaganda that I took him in my vehicle.
Yeah.
We didn't treat him well. We took him to a children's ward.
Maternity ward.
All the story
in the bucket of a pickup. Some say he was in a taxi and all that.
So
but what took him to the hospital?
Oh, an ambulance. Oh, yes. An ambulance. Okay. So then when I did the Tamils Institute, then after a while it became an issue. As if to say, why using the family name? Yeah. And so 2 years ago, you get tired of certain things.
Yeah. Who was the president, the late president?
He had a great sense of humor. He had a great sense of humor.
Oh. Is it true that, every morning when President Mills came to the office, you go around office and you say, in the Mechawa? No, but I'm sure you heard that.
Of course. Yeah.
They say we asked now to mean Chief Way. We were not there, but we had all these things,
Nothing scripted, very raw-hearty conversations. And to serenade us is the Top Strings Band. Join us at 7 p.m. prompt this Sunday only on Channel 1 TV. Every day across Ghana, stories unfold. Stories of hope, struggle, courage, and progress. At Channel 1 TV, we tell your story with truth and heart, giving voice to the people, holding power to account, and empowering change that moves our nation forward. Channel 1 TV, telling your story, empowering change. From Accra to Buin, every badge carries history. Every player brings a story. Every number means something. Welcome to World Cup Central, only on Channel 1 TV.
Hello and welcome to another episode of World Cup Central right on Channel 1 TV.
Your home of football intelligence with African energy and global perspective. We're taking you beyond the highlights, from powerful eye-opening stats to sharp breakdowns of every qualified nation to insights that change how you see the beautiful game.
Their first appearance was in 1930 and their best finish at the World Cup was third place in 1930. That was a long time ago.
Every Friday at 3 p.m. we serve it fast, bold, and electric. No fluff. I'm high and I'm
getting. Welcome to The Point of View. This is your favorite current affairs show here on Channel 1 Television. On The Point of View, we pick the right topics, get the right guests, and ask them relevant questions on issues that matter to you.
With the complexities of the issues happening around us on a daily basis, it's the hard-hitting conversations and the probing questions of The Point of View.
So what is the Public Account Committee's job?
So what we do is to scrutinize, clarify, and find out why certain infractions have been made.
What do these IMF programs try to do?
The current program is for budget support.
Okay.
There are no projects attached.
That teases apart the twisted entanglements of politics and governance, as well as religious and social discourse. The Point of View brings you the policymakers and duty bearers and drills down to the very bottom of issue.
What authority do you have?
The Point of View airs every Monday and Wednesday at 9 p.m. only on Channel 1 TV.
You're welcome. This is A Big Issue on 97.3 CTFM and on Channel 1 Television. Every weekend on Saturday, we bring you The Big Issue, where we discuss the big stories of the week. If the stories are big, they make it to The Big Issue. And we have the big brains to do the analysis for you. I am Omar Rusandamado. The show can be joined by WhatsApp 0539986996, 0539986996, or 0204447033, 0204447033, or on X, you mention my handle at Umar Rusanda or at City973. Do add the hashtag The Big Issue, and the world will hear what you think. Let me introduce my panelists in studio for the conversation, which is generally on health matters today, because we are looking at a number of issues. So the death of Charles Emisa and that Professor Ajimambedu Akosa committee, are we learning lessons from this so that we can say never again? That is what our hope is. There are also calls for the operationalization of a hospital in Weja that hospital is completed but not being operationalized. You remember what happened with UGMC? We had to carry Konko and metals and scream before it was eventually operationalized. We are having the same thing happening at the Wager Children's Hospital. What is the state of affairs there? Then there's this fight which to an ordinary person doesn't make sense. Laboratory scientists and doctors fighting over the management of a laboratory service or laboratory center in the Korle Bu Teaching Hospital. Is it the case that doctors are usurping the powers of lab technicians? Or lab technicians do not understand the scope of what lab work involves, for which reason this standoff is happening? Is it even a necessary standoff? So we'll be talking about that. Let me introduce my guest in studio. Directly facing me is Nana Kofi Kwachi. He's a public health advocate and country director for Aurum Institute Ghana. You're welcome, boss. How are you doing? Very well, thank you. You're looking very fresh. It's like the health problems are not affecting your personal health. It shall be well. Duncan Amwa is a representative of the ordinary man. He works with COPEC, Chamber of Petroleum Consumers. You're welcome, Duncan.
Sander, thank you.
How are you doing?
The doctors are here. I should be fine.
You should be safe, yes. If they say you are not fine, then you know you are not fine.
You know you are not fine.
I like how your grey beard is sharply contrasting with your dark suit.
Sander.
Yes.
I just saw a couple of that
on
my periphery, and then realized the days are counting for me as well.
Okay.
As all others. Unlike you with an all black.
Maybe I'm doing Yomo. You never know.
It doesn't look Yomo. You look very natural and still very young.
Thank God.
Thank you. The old men are here.
The Honorable Alexander Aban is former Deputy Minister for Health and former Member of Parliament. You're welcome.
Thank you, sir.
It's been 1,000 years.
Yes, you have not been looking for me.
No, it's because I wasn't the one who voted your party out of office. Then you decided to stop talking to me. You should be still maintain friends now.
In fact, I'm taking it cool in my village.
I can imagine. How are you doing? How is the law practice going?
It's going well.
Yeah.
We're hanging in there, so
that's good.
Small, we'll get there.
That's good. That's good. The Honorable Dr. Mark Ket Nawani is a member of the Health Committee. In fact, he's the chairman of the Health Committee, and he's from, I don't know, usually when I mention constituencies, the first MP's name comes to mind. So from Moses Asaga's Nabdam constituency.
Yes.
You're welcome.
Thank you.
How is he doing?
He's doing well.
He's doing well.
Yes, I was with him last weekend.
Okay,
yes.
Okay. And how are you doing yourself?
Oh, by God's grace, I'm fine. I'm fine.
Let's start with you. You have incurred the wrath of some people because you said, Ejumanu semunya amunyai. They are saying that doctors, they should stop the thing. If they won't do the work, they should just close and go home. That sounded a bit harsh in the view of some people.
Like you're saying, yes, it sounded quite harsh. And as a member of the profession, I really got a bit emotional. Yes. But of course, I wanted the medical profession to take a very serious introspection of itself. And probably, if this can lead to a reset of the profession, I believe that speaking as a member of the Medical Association from within, I think that I have a case, but probably it might have gone extreme, yeah.
Let's talk about the events that unfolded generally. So Charles Emisa was taken, he was knocked down by a vehicle. The people around tried to organize for him to be taken to the hospital. The ambulance sent him. I think it took 11 minutes for him to get to the first hospital at Reach. And he was rejected and then taken to Korle Bu Teaching Hospital. He went to 3 hospitals. The 3rd one just escaped me.
Yeah, the Greater Accra Regional Hospital.
Yes, so Greater Accra Regional Hospital, Korle Bu.
Korle Bu, that's where they ended.
Police Hospital, yes. Police Hospital is the first one. Yes.
Yes.
So that escaped. Now, 118 minutes. That's like 2 minutes shy of 2 hours.
Yes.
This guy was alive for that long before he died. Now, the committee has found that these people were negligent. You are a medical practitioner. I don't know where you worked before in the past, which hospitals you work with. The attitude of doctors and the attitude of the nurses appears to be the subject matter of discussion this morning. Is this usual? Do you see this and you're like, oh, this is normal, people do this all the time, or this is an exception to the rule of what happens in our health system?
Let me say good morning to your viewers, and also use this opportunity to commend the committee for bringing out these salient issues from their probe. Indeed, the Minister of Health said that when they are ready, that the committee is ready with their report, he's not going to shield anybody, and he's not going to hide the report. I believe that might have emboldened the committee for the first time to come out with not only the facilities involved, but even names of health professionals who should be invited for questioning or for action. And this is the first time that a probe has been set up and they've gone that far. And like I always suspected, that these explanations that there's no bed being used, sometimes to turn away patients, and in this particular case, for a patient to die, is something that we always accepted without questioning. And even as we speak now on the late Charles Emisa, there's a pregnant woman who died at Kaswa Children and Mothers Hospital.
Yeah.
And that patient was admitted for 36 hours in a facility. And when they were supposed to go and carry out a cesarean section to save her life and that of the baby, they said there was no bed at the recovery ward. As somebody who has passed through the system, I worked at Kolebu Teaching Hospital. That's where I did my housemanship. That emergency that they are talking about, I worked there. I went to Cape Coast Regional Hospital at the regional level. And I spent a year or two there. From there, I went to the Dunkwao District Hospital and spent 3 years there before renting a premises to start my own private practice. I've taken locum appointments at Techiman Holy Family. That's a CHAC facility. I've worked at the University of Cape Coast Hospital, also for a short period. Drobo and Kranza, those hospitals, I used to go there and work for short periods. And so I have a fair idea.
So you've tested both the city hospitals, the village hospitals?
Exactly. I've been in the practice for almost 25 years before coming into Parliament. And I still practice. So in all, I've been practicing for over 30 years. Yes, 33 years. And so I've worked as an individual, just one-man station. That is, in my private practice, that's how I started. An individual, one person working in a facility. Before, later on, that I started taking locum doctors, that is part-time doctors. And now I employ doctors to work for me whilst I come to Parliament. So what has happened, I don't know, but I believe that we should, as doctors and health professionals in general, take an introspection, self-auditing. You know, you can host this program, but after that, I believe that you have to probably see whether the program went well, it did not go well.
So post-mortem.
Very good.
Introspection.
Yeah, introspection.
But what? So based on all the places you've worked at, the scenario that we saw play out, is this a regular thing, or you think that this was an exception?
They do occur, even though I'll say that such outcomes, like causing the death of a person, is not that frequent. But they do occur, where sometimes I even think that a facility who could have handled a situation just because of, I don't know, sometimes individuals who don't need to ask so much for explanation. It could be on a health basis, it could be on this bent out that we talk about, or any other issue. refer to another hospital. And when you refer to another hospital, you are causing problems for another doctor who is there. Because if he behaves like you and continue to refer, then we have a vicious cycle of the individual moving, and this is what happened in this case.
Except that in this case, the referral was done at the gates. It was not as if the hospital admitted the person and said, oh, with this one we cannot, and so take forward to the next hospital. This one was as if he was rejected at the gate. And that is unusual.
Initially, that was what I was thinking.
Okay.
When they started this probe. But for health professionals to be indicted, it means that
there was a contact.
There was a contact. And if there was a contact, what did they do about it?
So it wasn't the security man that waved them off?
I don't think that the committee would have indicted if you don't know about it. Assuming that it is in the night, assuming that I was sleeping. Yes, I was sleeping, and I was not informed that a patient has been brought to the facility. Usually, they have rooms there that you can rest and wait for cases. So the doctor has to be informed. He could also be sitting down, working with the other staff on some other patients.
Without knowing that there's an ambulance outside with somebody.
Very good. He has to be informed. And you can only hold the health professional on if he has been informed. And what did he do? Now the next question is, what did he do?
So in this case, you believe that they must have been directly involved. That's why they were
in this
named.
case, they had knowledge of it.
Otherwise, it cannot be because they were vicariously responsible. No, they were directly responsible.
In this case, they were there, or they knew about it before the ambulance was asked to depart from the facility.
You are a doctor.
At the police hospital, I even understand that the doctor went into the vehicle and listened to the chest of the patient. That is good. But I don't have sympathy for whatever decision that he took, because this one was an external bleeding. Sometimes when there's internal bleeding, there's the likelihood that you not realize what is happening. But this was a cut.
There was evidence.
Evidence with bleeding into the ambulance. When you see this, without even the vital signs, you should be able to assess whether the ambulance people have adequately provided first aid or not. And if not, then the patient has to come out for you to do something about it.
You are a doctor. You are a member of the Medical Association. The Medical Association thinks that they were unjustifiably named and shamed, and that this was scapegoating. The nurses also believe it.
Whenever something happens for the first time, like names come out for the first time, there's the tendency for people to think that some people are being scapegoated. But let's look at the past. It has happened in Korle Bu. This might be so many times. And investigations have been done. Korle Bu has been requested, not individuals, to reform their system. There came a time that they asked them that, look, never turn away a patient. New policies have been developed. New instructions have been given. Rules and regulations have been given by the administration. And yet it is happening. Probably as a committee, if I was a member, I'll be thinking in a different direction. This time, probably, we should not stop by just naming the facility.
I'll come back, so I'll ask you how this punishment can even take shape, because understanding is that, and I spoke to your general secretary, the fact that this committee has done this work does not mean the medical and dental council would not have to do further probe, because these people would have to be heard and all of that. So I'll find out what the extent of this announcement is, and also what you as Parliament can do. Let me bring in Honorable Alexander Aban. You were once in charge of policy, which then involves our health system. You are also a lawyer. there's this issue of negligence, duty of care. The doctors in our hospitals, what duty do they owe patients? And in this case, would you say that truly that duty was breached? Secondly, what policy measures can be put in place to prevent this, if it can be prevented from policy level at all?
Thank you very much. Let me start on the note of condolences to the family of the late Charles Emisa. It is sad, but it has happened. I believe we will learn some good lessons out of this based on the introductory remark that you gave. But the question is, after 24th of July 2012, or 20, I'm talking about Professor Attamel's...
yeah, 24 July 2012.
Yes.
2012, yeah.
Was it not a watershed moment for us to have changed things altogether? Probably. That of Charles Emisa may do the trick. We hope so. Let us also...
So that's a bigger one. For you, that was supposed to have been our wake-up.
Yes. But let us hope that this would lead to some changes.
Except that we didn't have the reports in the manner we had in this case.
Exactly.
So we can't tell if
anybody was negligent
went through the same
like that.
Yeah.
Yes.
Mm-hmm.
So let us take it this way. The second thing I would like people to know is that nobody ever goes to the hospital, especially when you are taken there on emergency, and then you ask the doctor who is coming to work on you, are you NDC or are you MPP? Mm-hmm. Nobody ever does that, right? So in the discussion of things that have to do with health, education, and some other very important things of national nature, we should not make any attempt at all to politicize it. Because probably nobody has thought about it. Who has ever gone to the hospital and ever asked that, look, where were you trained? Are you NDC? Are you MPP? We don't do that. And that is why people who are taken there should be on merit and all those kind of things. Having said that, you were asking about duty of care and all that. So let me start with the law aspect of it. We say that there is duty of care not because you have a contract with a person. It is imposed on you by law. And so let me give an example. As soon as I sit behind the wheels to drive, for instance, the law imposes on me duty of care for all other motorists,
all neighbors,
and all other pedestrians, so long as they are within the contemplation of the law that in doing this act, you are likely to meet these set of people. People who are walking on the pavement, people who are also driving and all that. So you have a duty of care, or you owe a duty of care to all those people. So bringing it to the medical field, the doctor who is there has a duty of care for all patients. And if he is in a supervisory position, he even has duty of care to his own employees or the subordinates, right? Because in the event that the subordinate is even doing something and he himself also falls, you owe a duty of care to take care of him or her. So now let us take it just doctor, patient. So whoever is brought there, you owe a duty of care. That duty is measured against your level of proficiency. And so the level of care that we would expect from a houseman may not be the same as the level of care we expect from a specialist in that area. And so when we measure it against your proficiency, we see that you have fallen short of that. Then we say that you have breached that duty. It's not as though you did not even do any work, right? But if you did it in a manner which falls short of what society expects of you, you have breached it. So it's not only by effort, right? But that effort must commensurate with your level of knowledge. If you fall short of that, and then there is a resultant injury, and here we should define injury to mean to include death. So in this Charles Amisa situation, the resultant injury is the death of the young man. Once these three elements are established, then it means that the person who has been injured or the person who claims through the injured person can then bring an action against you as a doctor, and of course your facility, and most probably your employer. Right? So that is what we are talking about. But this no-bed syndrome, with a little time I spent at the Ministry of Health, I realized that it's not only about bed. We must understand it here and now.
It's not a non-existence of beds.
No. And I'm going to explain why. Sometimes somebody is taken to a facility. He is told that there's no bed. If the person is well connected, some call comes from somewhere before you realize there's a bed.
There's a bed.
Did they go and purchase that bed right there?
Definitely not.
Good. So it may have been a bed sitting somewhere. But it has to do with a whole chain of systems, processes, procedures, personnel, and even medication. Right? So your situation is brought there. The person who may be doing what we call the triaging, he is a doctor, right? Immediately realizes that no, this one we cannot even deal with it at all. If you're going to deal with it, we must have a specialist to deal with it. That specialist is not there. They will not come and tell you that the specialist is not there. They will tell you that there's no bed, so go. That's why I want you to understand that no bed syndrome must not be seen only as physical bed. But if that whole chain of procedures and processes, there will be a lacuna in that, and there will not be a complete unbroken chain.
So there's corruption, there's corruption, there's attitude.
All of those come together. There's likely that somebody will tell you that there's no bed. It becomes, if I say, a very easy excuse, okay, an approximation for almost everything that they may not be able to do. So that's how we should understand it. And that's why I told you that you go there, they say that there's no bed. And if you are well connected, within some few minutes, a few calls, and there's a bed. It should tell you that it's not only about bed, but sometimes it's about procedures and all that. The little I also learned, because the doctors are here, I only had an opportunity of using my law to go and supervise
their work.
Yes. So I had to at least learn a few things to be able to understand them. But the other thing that we must understand here is that it is not the physical building structure alone. A whole lot of things come together for you to now say there's proper healthcare system. Beyond the four walls or beyond the walls, there are a lot of equipment that must be in there with a lot of flow. They have a way of doing it. That is why when they are going to build a hospital, they just don't call any building contractor to come and put a hospital for us. No. There are flows that they do. And that's what will lead me later to talk about the wager problem.
So there's an entry point to an exit point. It's designed properly so.
Yes. Right? So apart from the building, we also have what we call the equipment in the facilities. Right? Then we will have what we call the personnel. Then beyond the personnel, we will have medication and all other, if I say, consumables. Right? It is this whole chain put together which leads to health care. And so the example that I gave, if you go there, this is a matter that must be dealt with by a specialist.
Honorable, the things you've outlined, the 3 hospitals are perhaps, if you take off UGMC, are the 3 big hospitals you have in the Greater Accra region. So if these 3 hospitals failed Charles Emisa, it cannot be said that the failure was as a result of inadequate facilities. If there is, then there's a problem. That they didn't have beds or they didn't have professionals. They should have professionals, they should have beds, they should have everything, because those are our big 3. And I'm saying if you don't add UGMC and maybe Bank Hospital, these are the big 3. Police Hospital, Regional Hospital, that's our regional hospital, right? The Rich Hospital is Greater Accra Regional Hospital. Kolebo is like the national or the primary hospital. So if these ones fail us, then we cannot just say that it's an infrastructure challenge.
No, that's not what I'm saying. I did not draw conclusions.
Yeah, I'm just saying that you've given, so I'm just looking at the picture. So we can't blame that. So what else can we blame?
Good. So this is what will lead us to the issue of attitude. What attitude? What is the motivation for one being there? Is it about money, or it is just the desire to save lives? Right? I witnessed a few things outside of this country, in the US. And when you go there, even as a foreigner, the way they would welcome you, treat you, even before asking about where's your insurance and all those kind of things, you will marvel. And you ask yourself, is not the same training that we have here? Because our doctors go there and they excel so well. Why is it that we are not able to replicate that here? Right?
Is it leadership?
Everything. Everything. Supervision is lacking. We know the Ghanaian attitude. Me, I will be paid at the end of the day. Yes. And I would not give names for now, but I would give examples where somebody was going for a surgery in a public hospital. The person's appointment had been postponed 3 times on the suggestion of a nurse that, you know what, I think you'll be better off going to a private clinic for this surgery. Lo and behold, this patient goes to the private clinic, and the very doctor who had been assigned to work on her at the public hospital was the one who did the surgery at much higher costs.
But in a private place?
Yes.
I've encountered that before.
Good. And so it gets to that point and you ask, is it the problem of the policymaker, or is it the systemic problem?
And in the case you just said, the doctor in the private hospital would behave differently than he does
very
in the public
professionally.
hospital. Yeah.
Very professionally. Why are we seeing that? And I'm telling you, yes, we can blame leadership to some extent. But if we ourselves do not even change our attitude, look, get the political class now, get all of them off, bring new sets of Ghanaians. So long as they are Ghanaians, probably they can even come and do worse. So the time has come that we may have to start complete reorientation of our mindsets.
We need a revolution.
Every good revolution starts from within. And so I know my brother, we went to parliament together and I was booted out. And we're very good friends.
Okay.
You know, he speaks impeccable Fanti, even though he doesn't.
I had the 2 of his speaking Fanti, and I was wondering when he did learn it, but he said he went to Cape Coast for like 1 year, 2 years. I don't think
to that extent, we have we are like brothers.
Where did you learn the Fanti, by the way?
Cape Coast.
No, I grew up in Prestia.
Oh, okay.
In the western region.
Okay. Right. So I know that you have been under some flack for some words that you use, but that revolution will have to start from within. And since he is a member, I think the current minister is doing something which we need to commend him for it. But it appears it has not come up. Honorable Akando, if you are listening to me, you know, we have all had this problem. As policymakers, you go there and because when we were talking about facilities and all that, I forgot to even talk about distribution, equitable distribution of medical personnel. Right? You post them to certain places, they would not go.
They will not go.
But I'm told that this time round, the minister says, look, everybody is going to where he has been assigned. And those ones, we are all guilty. We who call ourselves the big men in society, there's somebody who will come and tell you, oh, they have taken my son to this place. Could you please intervene? You go and talk to the people and say, okay, let's bring him. So you go to some facilities, some doctors are lying, working idle. Okay.
So too many doctors for a small facility.
Yes, and one person is, his back is being broken in some ramshackle village somewhere.
But how is the minister fixing this? For which reason you want us to commend him?
Yes, so I'm told that this time round, facilities, districts, regions will declare where we have vacancies, right? What sort of vacancies exist? Maybe if it's about midwives, or if it's about general nursing, or if it's about doctor, all those kind of things, right? And so when a portal is open, you just don't come and say that I want to go to this hospital. If they have not declared vacancy, they have not declared vacancy. As simple as that.
But you and I know that behind the scene you can still get these things done.
But it appears, that's what I'm saying, that it appears that
at least the structure is looking good.
The structure is looking good, and it appears he is also resolute.
Okay.
That whoever has been posted anywhere, the person must go. Well, I learned about 23 or so doctors were sent to OT. Only 2 reported. The rest were trying to get get to Accra, Kumasi, and all those kind of things. He has insisted, and probably now almost the rest are all going.
As I speak with you, he's in the OT region.
Okay.
We spoke last night, he's in the OT region.
Okay.
I'm sure he's connected to that.
Okay, so we must commend him for that. And stop this, nonsense of politicization of everything. Yes.
That should not be made to go. Okay,
yes.
I'll come back to you. Let me bring in my chief representative of the ordinary people.
I'm also ordinary.
No, you are not.
You are not.
You are not. Duncan Amwa.
Sanda.
The ordinary man
on the street.
Closed from work, Promasidor, Cowbell, North Industrial area. He used his motorbike, he was riding home, gets knocked down by a vehicle at Circle. The ordinary people around managed to help him, but the extraordinary people have failed him, and that's why he has died. That is the summary of the story.
Sanda, I would go to the genesis of our problems, really. And I think that whilst the state works to resolve some of the issues, just as Mr. Aban had indicated earlier.
Honorable Aban.
Ordinary Aban.
There's a problem, really. There's a problem. And until you get to be at the receiving end, you might think that all is rosy. And Sanda, sometimes until you fall ill and you are in need of some medical attention and it's being denied or delayed, sometimes not denied. The delayer can even kill you than the denial. So you get to a facility, whatever, they take your vitals, as they call it.
You join a queue.
Sanda, I have had personal experiences, not very, very pleasant. You can sometimes be in a queue for 2-3 hours.
Yeah.
And the pain only aggravates by the minute. And nobody seems to care. And so I think that, the Hippocratic oath that is administered to the doctors, they need to revisit it again. The 4 arms of that oath Some modern medical practitioners seem not to really care, and nobody seemed to take them on. And so, whilst my two senior brothers made their opening remarks, and one is actually commending the minister, I think that the minister should go a step further, not to seek to drive healthcare by himself alone. He would fail. I do think that if he really wants to be sure what is really happening in the various medical facilities, you should get mystery patients, you know. And oftentimes, for people like us who probably will dress well, you get to the hospital and there's some little respect extended. But for the poor and the downtrodden, sometimes you look at the way they are looked down upon. It is not funny.
It's as if it's a favor that is given.
It's a favor. And, well, I am a medic, and I am only here to help you. You are there to serve them, not to help them necessarily. You are there to serve. If you weren't there, somebody else probably would have been there to ameliorate that suffering or the plight of these patients. But sometimes it's the attitude to the patient. Sometimes under, if you are not lucky, like Honorable Aban said, you get to a facility, you are told there's no space. But the moment Sanda is your friend, and Sanda probably will be able to get to the minister and say, oh, minister, my brother or cousin is at 37. Yeah. Okay, hold on, let me make a call. Yeah. Things would improve. So healthcare, happens with
the ambulance service, happens with the hospital system.
A lot of our service providers in the country would rather wait for a big man to show up, you know, so that they can, oh, no, bring him here. There's, you know, bring him, and suddenly everybody's attending to you. That era has got to end some way, somewhere, Sanda. Because if you look at this Emisa instance, right, a Ghanaian is in pain. It's not even in a foreign land to have been said, well, they didn't care, and that whatever happens, happens. His own, kinsmen would look at him and turn him away.
You know the sad part? His sister is a doctor, an emergency medical practitioner. And I've heard this, that if that guy was related to any of the people in that hospital, he wouldn't have died. Maybe if they even knew his sister was a doctor, they could have helped. But if the brother of a doctor can go through this, then you...
Sanda, you see, again, you are coming back to the inhumane treatment that we met out to ourselves. So this is what the Hippocratic Oath is premised on.
That's the oath of medical doctors.
Yes, what the doctors
they swear by
when we commission them or they get into the medical practice. This is what it says. It's a solemn promise to practice medicine ethically. Prioritize patient well-being. Prioritize all. So I have seen in instances where some doctors themselves are not too well. You could tell that physically they're probably tired. They're sick. But they prioritize the patient well-being. They would also uphold confidentiality and avoid harming of patients. And so if you sidestep any of these, 4 codes or 4 things as enumerated, you are simply not living up to that oath that you took, just to be commissioned as a doctor to go and serve your people. And again, to add to what Honorable Aban suggested, people refuse posting also, even after they are commissioned, to some of these medical facilities, because as a country, we also don't plan for these medical facilities. We just go erect 2-3 blocks, put in a few machines, and we say it is a hospital. And then you post a young man who probably has not been fortunate to see the challenges in those communities, right? Probably he's lived in Accra, Kumasi, Takoradi all his life. End up, in the medical school. Suddenly you are told to go to a place where even accommodation, right, is a challenge. So I would again insist that we should have a medical fund, not health fund, a medical fund that does proper retooling of some of our health facilities. I was disappointed when we decided to go for taxes on, the betting, thing. It's not wrong if you want to tax people engaged in some economic activity. It's not wrong. But the justification had no merit. It was just like, okay, you are making money, I'm taking money. If you had gone to the Ghanaian, personally, I subscribe to this MTN health something, Anytime I buy credits, they do a deduction. And their promise is that if I get admitted in the hospital, they will pay a certain sum for every single day you're on admission.
An insurance.
An insurance. I subscribe to it. I'm sure millions of Ghanaians subscribe to that. If you had told Ghanaians, right, that you need a medical fund, Sanda, I could promise around this table, okay, where some of the groups that would agitate against new taxes and imposition of taxes.
If you explain.
But if you explain to the Ghanaian that, look, anytime you probably do a Momo transaction, just give me 0.5, not even 1%, to be able to put something in place medically for you. Most Ghanaians will go for this idea without blinking. If you told the sports betting guys, right, that anytime you make a winning, add something small so we can even put up a hospital in your village community. Anytime you travel for a funeral, like I'll be going from here, right, and on the way something happens, there could be a nearer facility that is equipped properly. So we don't have a medical fund, and we pretend all is well. We only build the good hospitals in the cities, Sanda, forgetting that a larger chunk of our people also don't live in the cities. And so if you happen to travel and unfortunately there's an accident, Sanda, it could happen to any of us. An accident on, say, Accra, Kumasi Road. You are in some village somewhere. The damage or the harm is so much. If you had a facility around immediately to stabilize you, something could help. There's nothing. You need to wait for ambulance. You would need to wait to be driven 2-3 hours to get to the nearest proper hospital. These things, I think that in our developmental stage, the current health minister has got a very good opportunity as a non-medical practitioner in that space to justify why sometimes public health administration can be better served by non-medical, because for the medical practitioner, their training, their orientation is usually about, the medicines, the things that they do in the hospital. The clinicals, yes. But for us, those of us out there, you should be thinking about a broader medical system, right? Such that the healthcare provision that happens in WA, right, can be the same that happens in Tema. If there's a private healthcare or a government setup, don't build these hospitals without providing for the nurses' quarters, doctors' quarters. And some of the nurses too have become truly a problem. Sanda, the advent of social media, you go to the hospitals,
TikTok,
you will find them rather busy with their phones as opposed to getting busy with the patient. And that's why I am proposing that Akando and the health ministry should look at mystery patients. Commission anybody. You could even send the honorable chair of
They know him.
Okay, they know him maybe, but not everybody will know him. Not everybody will know him.
You should wear jalabia and walk
Days he could just wear jalabia, some chalewati, and look very, very ordinary.
Maybe as a committee of parliament on health, you people should consider doing that one of these days without the cameras, or wear the camera that the Russian man wore, and go and do that.
Go in and say, oh, you will need to see a doctor, your stomach, blah, blah. Wreath in pain and be recording them. Sanda, if the minister decides to do this, I'm sure they will be able to flash out probably the 20% bad notes. A lot of the doctors are doing their best, right? But some too, they don't care. And I think that in order to unravel some of these things, we should be able to go in with the mystery patient, get things on record, and be able to punish. When you punish them, I don't think that the Ghana Medical Association, was it the secretary I had earlier? It's one of the reasons I came here.
You're not happy with
telling all of us that you cannot name people, who probably are negligent, or you shouldn't tell the public.
He said there's a systemic problem that should be dealt with. It's not their individual problem.
You see, Sanda, when a politician mistakenly takes your money, you would expect him to be dealt with. But the medical practitioner should not be dealt with publicly. I disagree completely. And I think that they should hold their own members to a much higher standard,
They
right?
say that the members who have been named are being harassed and threatened.
Sanda, clearly it's a report, right? If the report wanted to cover everybody and everything, then we shouldn't have had the committee at all in place. But it is good to expose some of these things so that if the nurses or doctors or any of these paramedics that were culpable of whatever negligence have been named, tomorrow if you're a medical practitioner, right, and the case is brought to your doorstep, tomorrow if they take me in a wheelchair and bring to your doorstep, at least you will be a bit more attentive to providing the health care that, the Ghanaian seeks. I do think that they should be able to hold their members to a much rigorous, higher standard than they currently are. It looks as though they are defending, somebody has lost the family, breadwinner or something, a brother to somebody, is gone. It is not he. So it's not a problem. But I'm sure tomorrow it comes to his doorstep. He will see the enormity of it. Sanda, I went to visit my mom sometime. They said, not well. And at the time, I think she was in Kumasi. You are called at night and told that, they would need money to attend to the patient. Flights will not go. You are forced to drive. And then you get there, the front people, right? Sometimes the security guys, their orientation, you don't even have an idea. The power they exercise under. Even when I had explained that my mother is on admission, they called to say that they needed money for some medication and blah, blah. So I'm here to say, no. It's not visiting hours yet. I am not a visitor. I'm coming to pay for a service to save a patient.
He doesn't understand.
He says that I should go and come 6 p.m. And I said, if my mother dies here, I swear, you bury me in addition. So, Sanda, some of the orientation, aside the paramedics, even the front men, right? You could be surprised that they may be doing the harm more than the paramedics. A patient is brought in, the security man says, we don't have any space, so try another. You get it. He is not even supposed to handle that kind of situation. But some of them are doing these things. So, Honorable Minta Akando, pay critical attention not only to the paramedics, but again, even the non-paramedic staff that you find in these hospitals. Because some of them, the danger they pose to both patients and people coming in to help is enormous. And that disrespects under. So I told the guy, look, you don't have a tourism facility. It's a health facility. I am not coming here for tourism. My mother is not well. They need the money. You can go and pay for me. And if you ask me to come tomorrow, maybe I'll come. But if you let her lie there without receiving the medication that she's been asked to pay for, simply because you stand here telling me that I cannot go in to make those payments, Sanda, you wonder. So the front men, whilst we are talking to the doctors and the nurses, don't forget these front men. Some of them are a real pain. And I think that the health minister should look at this mystery patient concept, deploy maybe 20, 30 to places that they don't expect, and let them do the filming. Then you can review these footages. Those that you find to be doing the care situation, fire them. Because they are continuously being there is a risk to all of us. This guy's sister is a medic, a doctor.
Medical, yeah.
I'm sure if they knew where she was, they would have taken him to him.
Yeah.
And he would have received the best.
Yeah.
So it could happen to anybody. Tomorrow, it could be my cousin, my sister, my brother, anybody I know, or anybody Sanda knows, or anybody the minister knows. So let's engage this mystery shopping thing. Get them clothes in very, very ordinary clothes, sometimes started. Because those are the people who receive the biggest disrespect at our health institutions.
Okay.
Sanda.
Thank you. Sounds like a great idea. Honorable Minta Akando, so that's a recommendation to you. And maybe I'm also thinking the health committee could also consider. Of course, we journalists can also do the same thing. But there was a time that the minister, I think, used to do these surprise visits to the hospitals. But that one...
They know him.
They know him. Yeah, so let me bring in Nana Kwachi. Nana, you are in public health. What we have seen, is it a failure of public health system or a failure of practitioners? Where do you place it? And what generally is our system looking like?
Okay, well, Umar, thank you for the question. And I want to echo the condolences to Charles Emisa's family and to all the many people in the country who have faced similar situations. Like Honorable Nawani said, this actually is a regular thing in our health system, but it's abnormal. And in fact, I think those of us who work in this space know that the fact that we see this happen so often and that over decades there hasn't really been any concerted effort to resolve it, it's, I mean, if I'm speaking from a personal perspective, I find it a bit obscene, right? Now, when we talk about this issue, I think for one, I understand the perspective of the GMA, for example, coming out for the doctors. I think what they're trying to do there is contextualize, not necessarily defend. I think what they were trying to say there was basically that there are broader factors at play here. So if we want to talk about systemic change, it's not enough to name 4 or 5 doctors. Bear in mind that they still have to go to Medical and Dental Council for due process. So they have not been found. There's a finding against them, but the MDC are the ones who resolve that ultimately. So I think we should give that process time to play out as well. There's also a question, like Mr. Aban mentioned earlier, around how we understand no-bed. And in fact, that submission is really critical to how we frame this conversation. No-bed is a shorthand. Healthcare workers use it to explain what really is a cascade of failures at multiple points in the system. And if we want to understand why so often we see this at Korle Bu, Komfo-Anokye, Tamale, the big hospitals are the ones that seem to be the culprits, and why that tends to make us feel like they should be able to do more, we have to really understand the full picture. In 2022, we did a harmonized health facility assessment in Ghana, looking at all health facilities below the teaching hospital level. This was done by Ghana Health Service, the WHO, and the Ministry of Health. And if you look at the findings for that and you consider the structure of emergency care in Ghana, you can see the red flags all over the place. For one, the way emergency care is supposed to work is you're supposed to be able to get emergency care at the closest facility to you. So we shouldn't be seeing the scenario where everybody is being sent to 3 or 4 hospitals at the very top. We have district hospitals that are supposed to be able to pick up some of that slack. We have regional hospitals that are supposed to pick up that slack. We have other general hospitals that are supposed to support that as well. Those are the shock absorbers that allow us to retain the capacity at the teaching hospitals for the most complicated, the most dire, the most complex situations that require specialist care. But unfortunately in our system, that's not happening. And why isn't it happening? If you look at some of the things around Charles Emisa's case and you consider what's available at the district and regional level, you start to see some of the challenges. Again, from the harmonized health facility assessment. Airway intervention is, when we do emergency response, ABC is what they call it. Airway intervention is the A. Only 4% of facilities that were surveyed who are supposed to provide emergency service, only 4% of them had all the essential equipment you need for airway intervention as of 2023. 2% of them...
And what is that intervention? What did it contain?
That's how they make sure that your windpipe is not blocked, okay. You're actually able to breathe. All the equipment that's required for that, that's what we're talking about there. Okay. And we're saying that as of 2023, 4% of facilities that provide emergency service had that. 2% had all the equipment for circulation intervention, that somebody has a heart attack and we need to do a bypass of some sort or get the blood flowing, 2%. Safe blood transfusion was only available in 15% of emergency offering facilities. If you looked at all the essential equipment for cardiac intervention, how many of them had all this equipment on site on the day of the survey? It was 0 in 2023. If you look at things like defibrillators, basic resuscitation machinery, 69% of regional hospitals had it, but district hospitals was 43%, and other general hospitals was 32%. You look at who can do rapid 24-hour emergency transport, only 15% of them. You look at how many of them have basic medicines for emergency, aspirin and adrenaline, under 40%. So what you're looking at is a scenario where below the major teaching hospitals, effectively, the emergency care system is paper thin. And because of that, everybody is being channeled up to these teaching hospitals that are supposed to have the capacity. So they have the personnel, they may have the equipment, they may have the space and medication, but if everything is being trafficked there, and as we saw in this case, without advance notice from the ambulance service, because we don't have a system that can do that, without advanced description of what the needs are going to be so we know how to prepare for the patient, then you're going to have a scenario where doctors who are already overwhelmed, working with absolutely at capacity emergency rooms, also have to figure out how to balance out quality of care for patients at admission and for those that are now coming into the ward fresh. And that decision point is where a lot of Ghanaians see the failure. So that's where somebody may say no bed because they may not be a specialist, or they don't have the defibrillator, or they don't have the other things that they may need there. And I agree that sometimes how that's communicated, how that is framed, and some of the behaviors of some healthcare workers exacerbates the experience that patients have of that. But the reason why the no bed issue is coming up is not because necessarily, primarily because of a clinician's preferences. There are a whole series of failure in the cascade. In Charles Amisa's case, we are told from the Bidua Kosa committee that the emergency team on the ambulance was not able to intervene for him to stop the bleeding. Part of the emergency response is what can happen to you in transit. That's actually what gives you the highest odds of success once you get to the facility. If we're saying that our ambulance service doesn't have the correct configuration on every ambulance to make sure that something as basic as compressing a wound can be done, or we can provide fluids or maintain constant monitoring of vitals. Again, that's not attitude question, that's configuration, that's equipping, that's resourcing. Now, there's also the question about how we organize the system. I think this has come up already. We know that in emergency care, there's supposed to be routing and prioritization. We're supposed to have triage SOPs. We're supposed to have some kind of funding mechanisms that mean that people don't have to wait for financing to get emergency care. All those things are very much nascent or non-existent in our space. We don't have system-level visibility. We don't have ability to know what capacity exists in the private sector. All these things come to bear in that interaction between the patient and the physician when they are being told there's no bed. All these things are what no bed means. So in trying to assess what we can do going forward, I agree that we should be interested where professional misconduct or professional failure is the primary cause. But when we are trying to think about how we prevent it from happening again, sanctioning those healthcare workers is not going to solve that problem.
Really?
It's part of the big picture of justice. If the MDC finds that there's cause for sanctioning them, but that is not going to solve the problem of a cascade of failures at district and regional hospitals.
It won't deter others?
It would deter others from the misapplication of their practice. But if I have a patient and I don't have the things I need to care for the patient, what does attitude have a role to play in that? I can try and innovate around the situation. I can try and figure out what I can do. But if I don't have a defibrillator and there's somebody crashing in front of me, I can't do CPR for 3 hours, right? So
better not to receive the person for the person to die on your hands than to receive. Okay, so better not to receive the person. So you send the person away and say, I cannot. That's your view?
It's not my view. It's what is pertaining on the ground.
That's the reality.
That's the reality on the ground, that clinicians and hospitals are saying that we are at capacity. We don't have the personnel, staff, equipment to take responsibility for this life, and therefore we cannot admit this patient. And it happens elsewhere as well, not just in Ghana.
So you don't agree that it's an attitude issue?
I'm not saying it's not an attitude issue. I think an attitude issue plays a role in how the problems are communicated, how patients are handled. And I don't disagree with the fact that it is true that people can call in, use privilege and power to navigate around that. Mm-hmm. But every time that's happening, it's not happening because there's some spare bed available that no one was bringing up. It's happening because somebody else's care is being compromised for this other person to be accommodated.
Are you sure that's what happens? Are you sure that they take off someone from a bed to give a new bed to someone? I don't think that happens. There possibly would be a bed. There could be a number of reasons, but you are the practitioner here. This issue of someone calling and saying, Charlie, my relative or my cousin or something, and then a bed is found mysteriously. he thinks that they take somebody from that bed for you or person to benefit.
No, I'm not saying they take somebody from the bed.
Okay.
I'm talking about, like we said already, the emergency care is not just about the bed.
Yes.
It's about personnel. It's about equipment. It's about life support machinery.
Yeah, so how do we find that solution immediately a phone call comes through? I don't know if you can help us.
Well, sometimes a bed can be created, yes. Because that's why when you go to emergency, patients are classified. The critically ill,
so
the less critically ill,
depends on why the patient is coming.
Who are ready to go to the ward and other things. They are all occupying beds.
Exactly.
So that if somebody who is very ill comes, sometimes they can beg even a patient that, oh, we have finished with you with your IV fluids, we've gotten your vein. Can we put you here and bring this patient and come and put the patient on a bed so that, when a patient is high, the lighting system is good and you can assess, let's say, the vein. I'm only giving an example. And bring that patient and come and put there and work on that patient too.
So that's how a bed gets produced.
A bed
It's not from a vacuum.
Okay.
There's a rationing decision that has to be made.
Sometimes you appeal to patients, they agree.
Yes, but unless a phone call is made, you can't appeal to those patients.
No, that is why I'm saying that we as practitioners, we need to make the best of our decisions.
Okay.
We shouldn't wait for a phone call.
Okay.
Exactly.
Yes. We should look at the condition of the incoming patient.
Exactly. And that's my point exactly, right? That it's not that if we are in a ward that has 4 beds that have ventilators and people are on the ventilators and I get a fit patient, it doesn't mean we don't have capacity to do ventilation or the equipment. It means we have the things for ventilation, but we don't have the capacity in that moment because everything is full. If somebody comes in and the call is that the person has, a lower level, something that's triage lower level, green or blue, for example, stomach pain, something that's not life-threatening, you can make space somewhere to put the person. But if somebody comes in where they need that critical care and you are trying to figure out, how do we make the space, you are doing a rationing decision. And that's why we're saying that rationing decision happens because healthcare workers are working within the constraints. And it's sometimes the way they make that decision and the way they communicate it that comes across as cold or dismissive. But the rational decisions they have to make are also tough decisions. And sometimes the reason they are making them are not just about the random occurrence of having too many health patients on admission. Sometimes because they just don't have the things that they need to expand out their capacity. And if we say that because that's what we have to be careful about, that healthcare workers will make rationing decisions. They make that all the time. And a lot of the time they are making somebody a little bit inconvenient to provide somebody a lot more care. That's how rationing works in healthcare. But we have to understand that, like we said already in the committee reports, SOPs for triaging and prioritization are not used everywhere. Some facilities don't even have them. And so if we don't have a rational way to do that, to figure out capacity at national level, where can we send this person? How can private sector play a role? What are the options to navigate or redirect? Then we are creating all those decisions that are solvable by systemic planning, come down to the clinician in the moment. And when they fail in that effort to make the best judgment, where it's professional misconduct, they are culpable, for sure. But where it's because they lack information, they lack clarity, they lack foreknotice, they are dealing with information overload already, we also have to be mindful that that's a reality and weigh out these two things in a balance. So we know that, yes, there's behavioral things that can be addressed, but what I read earlier to you in terms of the state of emergency care at distant regional hospitals, again, 4% of emergency facilities being able to do airway intervention, the A of emergency care, that's damning. So we can't look at long-term systemic level solutions and focus it on just attitude and what healthcare workers do or say, because they are operating in a system that creates that culture. And that system is what we've described.
So we need a revamping. This, I'll come back around the table so we can find a solution to this and move forward. This is the big issue on Channel One Television and on 97.3 City FM. We are having discussions around the issue of Charles Emisa who has passed away and the committee that has done the work. Let me bring some of your messages and then I'll take a break. This one says, most often, the doctors know that whatever the situation, their unions or associations will come to their rescue. This always emboldens their negligence. This report must end the needless lives lost, not to talk about numerous wrongs, medications that end lives. This is from Jose Aduboy in La. This one says, hello, good morning. I'm listening to you from Ashalebotri. I visited the US years back and was ill, and I was taken to the hospital and the care was top-notch. They didn't ask for anything. I always say these people are blessed because they prioritize care and put humans first. We use connections and whom you know, and day and time, any day and time in our country. It is sad. That is a message. You can also send yours, 02044 77, so 02044470033 or 0543 986 996, or go on Twitter and mention my handle at Omaru Sanda. This is the big issue.
Up your sound experience with the We Hear speakers by Lovi. From the sleek We Hear 1 to the powerful We Hear 2, and now the premium We Hear Pro, fully endorsed by Kylian Mbappe. This is not just a speaker, it's a flexible, high-performance outdoor Bluetooth speaker built to bring your music to life anywhere. With up to 100 watts of music power, you get bold, immersive sound wherever you go. All available in stylish standout colors. Now the good news, from April 20th to May 20th, grab yours at a special discounted price. The We Hear 1 now at 400 Ghana cedis, the We Hear 2 at 900 Ghana cedis, and the premium We Hear Pro now at 3,800 Ghana cedis. Don't miss out. Call 020-195-7739 or pick up at the Atlantic Towers. You can also grab yours at Orange FM Kumasi, Plus FM, or 3 Music TV in Accra. Number 12 Afunya Street at Belengpe. Don't miss out on this special discounted offer. It's the We Hear promo, powered by Lovi. We Hear, feel the power, hear the difference.
This Sunday, we continue our conversation with Samuel Koku Anyidaho on the Upside Down Show for a candid conversation featuring the Mills Institute.
In fact, when he passed, a lot of propaganda that I took him in my vehicle.
Yeah.
We didn't treat him well. We took him to a children's ward.
Maternity ward.
All the story
in the back of a pickup. Some say he was in a taxi and all that.
So
but what took him to the hospital?
Oh, an ambulance. Oh, yes. An ambulance. Okay. So then when I did the Tamils Institute, then after a while it became an issue. Mm-hmm. As if to say, why using the family name? Yeah. And so 2 years ago, you get tired of certain things.
Yeah. Who was the president, the late president?
He had a great sense of humor. Oh.
Is it true that, every morning when President Mills came to the office, you go around office and you say, in the Mechawa? No, but I'm sure you heard that.
Of course.
Yeah. They say we asked now, Dominche Fanway. We were not there, but we had all these things,
Nothing scripted, very raw-hearty conversations. And to serenade us is the Top Strings Band. Join us at 7 p.m. prompt this Sunday, only on Channel 1 TV.
Welcome to The Point of View. This is your favorite current affairs show here on Channel 1 Television. On The Point of View, we pick the right topics, get the right guests, and ask them relevant questions on issues that matter to you.
With the complexities of the issues happening around us on a daily basis, it's the hard-hitting conversations and the probing questions of The Point of View.
So what is the Public Account Committee's job?
So what we do is to scrutinize, clarify, and find out why certain infractions have been made.
What do these IMF programs try to do?
The current program is for budget support. Okay. There are no projects attached.
That teases apart the twisted entanglements of politics and governance, as well as religious and social discourse. The Point of View brings you the policymakers and duty bearers and drills down to the very bottom of issue.
What authority do you have?
The Point of View airs every Monday and Wednesday at 9 p.m. only on Channel One TV.
Hello and welcome to the Channel One Newsroom from our studios at number 5, Ola Hansen Lane at Tesano in Accra. I am Nanatifu Obwati.
I'm Frema Edunyame.
I am Umaru Sanda Amado.
I am Inesafo.
I am Charles Owusukumi.
I am Makosia Otrick.
They've given you land to build an airport, and the airport is named after them, and then you are going to change it and put your name. We hear a Jumara National Apprenticeship Program in Kokon Kete. Well, they are paper.
A terrorist attack in Burkina Faso claimed the lives of 8 Ghanaian tomato traders.
Our fire extinguishers, they are empty. In the market, our fire extinguishers are empty.
There's a bill Ghanaians have been working for. It was one of our flagship strategies for economic transformation.
What do we have to do now for you to call off the strike?
The others also, did influence the voters.
Prof, what becomes of these students, especially the continuing ones?
They should reverse everything that they have done.
Channel One Newsroom airs Monday to Sunday at 8 p.m. only on Channel One TV. The 2026 FIFA World Cup. But before the first whistle cuts through the noise, there's a deeper rhythm to the game. Every badge carries history. Every player brings a story. Every number means something. Welcome to World Cup Central. Only on Channel One TV.
Hello and welcome to another episode of World Cup Central right on Channel One TV.
Your home of football intelligence with African energy and global perspective. We're taking you beyond the highlights, from powerful eye-opening stats to sharp breakdowns of every qualified nation to insights that change how you see the beautiful game.
Their first appearance was in 1930 and their best finish at the World Cup was 3rd place in 1910.
With challenges, we all need guidance, hope, and a lifeline to anchor us.
This is Lifeline, and I'm your host, Fred Crunchy Mensah.
From social issues, relationship challenges, and family matters, Lifeline is here to inspire, uplift, and guide you on your journey.
Where we give you support, where we hold your hand through the valley and through the thick and thins of life.
So you're welcome back. This is a big issue on 97.3 City FM and on Channel One Television. We are talking about the issues that we have identified so far. So we are sort of seeing the challenges with our health sector, and we've seen that some people are being punished. Is the punishment enough? Should they even be punished at all? Should we rather fix the system? Are we backing the wrong horse and all of those things? So that's what we're looking at. And now we're going to find out also what the solution would be. I'm going to go around the table again, and I'm going to start with Doc again. Is it the case that the system is bad and we've decided to attack the people? So is it the problem, is the system the problem or the people?
Sana, whenever these issues come up for discussion, we only remind ourselves that we're a lower income country, we're a developing country.
We're a poor country.
We're a poor country and we have a lot of problems. And for example,
we are poor and proud country.
When we want to discuss this issue, we will start saying that, the government needs to provide more hospitals. The government needs to equip.
Akufo-Addo saw it. He said he was going to build 111 hospitals. Your government, you are not doing it.
No, but he didn't complete one. If you had
completed
the
first one, he found land and did foundation. But he did foundation.
Block work. If I've ever built, the block work is no work. Yes. No. If I ever build, you know, block work.
I know, but at least he started. He has started something.
Yes, and we will continue.
By taking forever. I thought there was this plan.
But we need to cover out about more than 1.2 billion, and it has to take time.
Okay.
First, we need to look at the economy, and that is what exactly we started with.
But prioritize health.
We have to prioritize the economy.
He collapsed the
for the
hospital.
economy to
At least
yield,
try and build a large
for the economy to yield, for the economy to yield about 1.2 billion, for us to now push into the healthcare sector.
Big push.
Into the healthcare sector. Yes.
Hey.
No, that is supposed. You need to look at the smart investments.
Yes.
Get returns, and from the returns, you now make the push. Remember that we've not gone to borrow from the European bond market.
Okay, let's go. Let's leave the economy. Let's come back to health.
We are managing with our own resources. Yes.
You are doing well.
Yes, I think that is exactly what we are doing. Yeah. But we always miss the point because we are talking of more equipment, and like he said, the tendency for it to be turned into an NDC, MPP, who provided more this, who provided more that, and we miss the point. The point is that an individual got injured, bleeding from the arm, visibly and externally. As a medical professional, if even on the streets you met somebody lying down like that and you assess and the person is still alive, what will you do? This is a question we have to ask the hospital staff, let alone being transported from the roadside
and brought to you.
We've
had instances where doctors...
And the question still asks, what did they do?
We've had instances where health practitioners on an airplane, passenger airplane, rises to the occasion and saves the life of somebody on the plane. No oxygen, no nothing.
I did it on passion.
Oh, you did it on passion air?
I did it on passion.
Okay.
Passion air. An elderly man just had his head backwards and was foaming. And when I was called, I just turned the head down this way and gave a blow to the chest because I thought something was choking him. I didn't know what was choking him, but something was choking him. And when I knocked the chest, he started coughing. And after that, he regained consciousness. And when we were speaking to him, he was still confused that he didn't know what happened, and I think he had difficulties in breathing. Yes, he might have aspirated. I don't know whether something falling back, the tank or any other thing falling back, or just this mucoid, this thing that came out when he coughed. And he immediately we arrived, he was sent to the airport clinic, and from there they took over and then this thing. But that is exactly what a health professional can do. At that particular point, I had nothing but just by looking at that patient, I realized that no, he has stopped breathing or something that is choking him, and because he was foaming, which means he couldn't even swallow his saliva. And so the same thing, I asked this question, assuming that this patient who was bleeding was lying at the roadside, and you got there as a health professional. I don't know whether because we are old practitioners, but there have been times that I've ever held a patient bleeding at some point without gloves.
You adrenaline just pushed in and you
pushed
just...
in and I moved on to hold the patient's hand like this and now asked for a tourniquet to tie.
You had empathy because you have children and grandchildren.
And later on that I went and did the amputation of the arm after we resuscitated and other things. So what I'm trying to say is that we're not complaining about the action that they took, but we're complaining about the inaction. And let us always handle it case by case. Instead of generalizing that, yes, we need equipment, we need this. When we do that, we miss the point. And when we do that, we are not able to fix the problem.
But are we also not being hypocritical when we make a statement like this? Because you can't drive a vehicle where there's no vehicle. If there's no oil or fuel in the car, you cannot drive. And they are saying that the logistics they need to do the work is not there. You have worked in the public hospitals.
Yeah.
You know how they look. You know where they are. Kolebu is our foremost hospital. But when you go to some of the departments
they complained that there were no logistics.
Even the lift that carries you at the Kolebu Teaching Hospital.
I don't think that they were complaining of no logistics, no consumables, nothing, no IV fluids.
But no bed, he has just explained to us that no bed is not just a bed,
look at,
but it's a chain of events that is
at
now...
At Kolebu, they gave them the stretcher, put the patient on, do something. What did they do?
Yeah,
it is the inaction.
Yeah, but he has explained, I'm saying that, he's saying that we just use a no bed as a short form of yen to me, like we cannot, because the overall problem
let us not give any interpretation to no bed. No bed is an English word. It's an English word.
But it's a headline. Under it, we have sub-headlines.
Yes, no, it's an English word. Let's not say that no bed means no health professionals, or no equipment, or no drugs.
So it's inertia. And
it's an English word. Let's just take it that way, and let us stop using that as an explanation. We don't deserve that as a nation. We have the short term, what you should do, the medium term, and then the long term. So all that my good friend has been speaking about, they are all good. They are in line, but some of them are medium term, long term. But for a particular case, this man could have been my brother, my sister, my mother. And if that person was sent to a hospital, what will you do? Assuming that any of those working there, it was their relative, what would they have done?
So for you, despite all the challenges, this was purely an issue of the doctor not acting right. So these 4 doctors and the 3 nurses, they should be punished.
They have questions to answer. I'll say that way. And like my good friend and the lawyer said, the Medical and Dental Council will pick it from there. The committee has finished its report. The minister has directed the chief director of the Ministry of Health to write to the Medical and Dental Council and to write to the employers to take it from there. They are laid down procedures, regulations, not because of this case. They've been there for some time. Yes, they will be subjected to it. But of course, we should look at mitigation factors. The Ghana Medical Association has stepped in. I believe that they want mitigation. They want to come in and see how best the individuals will be handled fairly, and probably whatever they want to do to them, it could be within the law or even reduced punishment. I am actually, like I'm saying, I said they could resign, and it has been misinterpreted to mean that I'm saying that they should leave the medical profession. No, after 10 years of training, you train for about 6 years, then you go to specialize for about 3 years or 4 years, and that's about 10 years of training. I don't expect that they should leave the medical profession, but whatever has happened now.
But you're saying that if they won't do the work, they should go. That's what you said.
No.
You also spoke English. We understood what you said. Oh.
Yes, you understood. If you are sitting down here and you not come and read the news, what do you do?
Yeah, go home. Go home. So that's simply what you're saying.
Go and think about what you do, but it is a call.
Okay.
It's like it is a call.
Because you don't come and
it's not when you're jai, but let's just yes. Say empty me here. Because thank you.
Do you agree that it's a system that is faulty and let's fix the system, or you agree there's a personalities involved who are the problem and it's good to punish them?
I agree that many things or all other things that put together to provide healthcare needs overhauling. Right? Good. So it's just like preparing some soup. a lot of things will have to come together to give you very good soup.
So that if they are to be punished, it's in order.
Oh yes, yes. It does not necessarily mean that because the system is broken or the system is not perfect, you must set that one up as an example to also be negligent. No. So let us start from policymakers. Government must make conscious efforts to make sure that at least the buildings, the equipment, the consumables are available. That's at the policy level. Okay? And here, I'm resisting the temptation to sound partisan. But governance is a continuum. And we must understand that whatever has been put down there is taxpayers' money. And so we said we're going to do Agenda 111, right? We have been unable to complete. We have been unable to complete Agenda 111. It does not necessarily mean that because government has changed hands and this, excuse my language, this nonsense of, oh, this is what we yes.
It's painful.
Okay? This nonsense of saying that, oh, this is what we promised. Okay? That was started by the previous government. And so we are not going to do that and all that. It is nonsense. I think we should stop it. You see, maybe mention can be made of some 5 hospitals, this Sewia and all those kind of, you remember, is it the Eurojet project?
Yes.
Look.
The ones that Mahama used to do beautiful hospitals for us, like Ghanai's hospital.
Since the time that I went to the ministry, it has been back and forth, back and forth. I believe now they have completed all of them in their operational. Look, that's why I said anybody who goes to the hospital is not going to ask whether this was done by NPP or whether.
But you see, because you are doing politics now, let me remind you, they pull down the La General Hospital. It's too rubble. Down there, down that in there.
No, but I think
you're not done well.
I do not want. That's why I said I just don't want to sound partisan.
Okay, me too. I don't want to remind you.
You have reminded me already. But I think I saw that project was they resumed.
Yeah, now this people have started doing it. But when people left,
so in that same spirit, we must let me admit here that probably the Agenda 111 was just too
ambitious.
Ambitious, probably, because the amount of money that has been sunk into all of them, most probably, if we had selected 10. And said, let us complete them.
Start from somewhere.
Yes, that money probably would now have been in operation in terms of hospitals running, right? They would have done them in phases.
So we beat more than we can chew.
Most probably.
There was an indecent haste.
To
give contracts.
Akufo-Addo was in a hurry, please allow.
To give them out as contracts. You see, that is where we have to ask.
We are getting to the politics.
Why do I want to give out this contract when I don't have the money?
I would never take the bait of your partisan.
Thank you.
Words.
Don't fall for it.
I won't. Right? That's why I say that governance is a continuum. The fact that somebody thought, oh, we could do 111 across the country. And you see, we must not take it in isolation. We had come out of COVID. And we saw how we got exposed when COVID came. So it's not as though somebody just sat down, oh, let's go and do 111 and that's it. No, we had a history behind us. But if in the implementation of that grandiose thinking, we could not finish all of that, it still remains that whatever is down there is taxpayers' money. It is for this reason that if a new government has come in, they can say that, you know what, we may not be able to continue all the 111 at a go. So where we have reached very appreciable stage of completion, let's complete them.
I think they're doing that. I think that's the approach they are using.
Okay, let's complete them. And then we can have them in operation.
Okay.
Right? But if we say that, look, for us, we promise 24-hour market. So we are going to do that. Let us wait.
But that's what Ghanaians voted for you for. You have to
Don't worry.
give them what you...
Don't worry. Let's wait against the priorities of the nation. Are we sure that when we build Agenda 111, when we build 24-hour markets, we are going to have that same, if I say, return in terms of the quality of health or the quality of life that people would get if we put the money in completing these hospitals? So we'll say, okay, that's what we promised. And so that's what we want to do. And especially when our basic economics tell us that the issue of demand and supply, the forces of demand and supply, is what will determine whether people would want to even go out there in the night to even transact business. So we live to see. Right. I'm not a prophet of doom, but if we don't take care, we may end up putting up these markets, and we will not have any evening trading. We may not even have evening trading, much less in the night. So let us think deeply about it, right? And try to prioritize our health.
Okay. All right.
Okay. So for me, I would say that the policymakers must do their bit. Dr. Yankson, Lawyer Yankson is here, right? Yes, sir. I know you are a doctor and you are a lawyer. And what I'm going to say affects you as a doctor, but not you personally. Beyond what the policy makers will have to do and have the political will to do it and do it well, and not necessarily because we have to award new contracts so that we can we also have to deal with the personnel. We need to motivate them, but they also need to have reorientation of their own calling as professionals, right? Because the example I gave you, it's very sad. Why would you go to a government facility, a doctor is billed to carry out a surgery for you, he postpones it 3 times, somebody advises you to go to a private clinic, you go and it's the same doctor.
Ready to assist you.
Not ready to assist you. Went ahead to do the work professionally.
He's wearing a different lab coat in that one.
And took good money for it.
Yeah.
So most probably we have to also look at motivation for them.
Okay.
And they also have to look at their own reorientation, okay, to fit their calling as professionals.
All right.
Then the rest follow. But you see, sometimes you realize that as we speak, there are a lot of nurses who have not been posted. Not because we don't need them, but it appears that when government decides to take them on, the wage bill will be so big that it will affect the economy. So sometimes government needs to even be forthright with us, right? Because you go to some health facility, very few nurses. You go to some health facility over and above their immediate requirement, right? Distribution is an issue, and that distribution has to do with both policymakers plus the leadership of the various health institutions. For instance, either you talk about CHAG or you talk about Ghana Health Service and all that. So if we stop these issues of influence peddling, where somebody will come and say, hey, that's my son, he cannot go to that village, he must be in Accra. Because as at now, doctor is here, about 80% of our medical practitioners are in Accra and Kumasi. If I'm lying.
They won't go.
That's true. They won't go to the other places, right? Then we have the consumables and all that. But what about those who cannot pay? How strong is the health insurance now?
Mahama has brought primary health care, free primary health care, to complement doctors.
Where are they taking?
Dr. Nawani, I'm doing your propaganda. I'm doing your communication for you. I'll send you for a bill. Continue, Honorable.
Okay, is it not still from the health insurance money? And so, if you strengthen it well, do we? Because sometimes we duplicate and give names, okay, just to satisfy the political campaigns that we made.
Okay.
Because there are a lot of programs that have come. You look at it in terms of substance, it's the same, but it has different name. Maybe.
Right. Let's leave it. Let me introduce Dr. Justice Yankson is a lawyer, like you said, and also a medical doctor. We work together to build the emergency medical center.
And my friend.
And he's also your friend. Doc, you're welcome.
Thank you, Larry.
How are you doing? I haven't seen in a while. The gray is coming on. I haven't seen it. Or is it local? Maybe it's too much local.
No. Personally, I think I haven't done local since 2010 or so.
Hey, so how are you surviving? Because the government pays not that much.
Yes. That's why I try to wear a second hand.
It's necessary.
I've not been seeing you in the court.
And I think practice no any na no your court.
So you're doing some serious transactions. I see. We'll talk about
it. He's a legal advisor for the Agenda 111.
I see.
Very consultancy.
But you are the one who opened yourself up. You say you are doing private consultancy. And that's what I can come up with. Dr. Yankson.
Yes, bro.
Charles Amisa's death. 4 doctors are blamed, 3 nurses are blamed. Do you agree that that's where the blame should be, based on everything you know in medicine and also what you know on the duty of care to your neighbor?
Okay, so Omari, thank you for this question. Let me say my condolences once again to Charles's family, especially my colleague Dr. Amisa. This was a tragic one. I think we should all accept that fact. But it has also given us an opportunity to probably, as a country, move away from, in quotes, all the wrong paths that we were on to the rightful paths. And a lot will depend on the states. Let's be honest. In this country, healthcare is dominated by the states, unlike elsewhere where the private sector seems to. So a lot of bits will mean that the state has to take an active role. Even our own constitution mandates the states to ensure that we all have access to good health and all the related things. So this is something we shouldn't take on a light note. I hope that for once, maybe this will be a turning point. In as much as I have some optimism, there's still some
doubts.
You see, I didn't want to use those 2 words, but the truth is that is what it is. All because we have traveled this journey before. This is not the first time. Look, in my work with the Medical Association and all of it over getting to almost 2 decades, I have seen this play out so many times. The Medical Association has had calls to do position papers, public lectures, annual general conferences, all on emergency care. We submitted document, policy directions, and all the things that we think will help. And the things we are talking about today, they are all in those documents, but they are still on the shelves. If you go to the ministry, if you go to the presidency, you find all these things, because when we circulate widely to as many as we can in terms of the decision-making process.
So the problems have been codified?
Yes, well codified. Doc is here, he knows. He's one of us, he knows. He's been on the health committee. I have made personal appearances before them on some of these issues. So these are things that we should not just say it came out of nowhere. I recall in recent times, if for nothing at all, from the point where the Right Honorable Speaker of Parliament was Health Minister, I discussed these things in his office with him. And since then, there have been about 5 or 6 health ministers, and I'm sure each of them has, at one point in time, had some experience or some issues bordering on this no-birth syndrome. And we are still talking about it today. So our true commitment to let this be a turning point for our common good is now what has to be tested. And I hope we don't fail this time. Okay. Now, on 4 or 7 professionals being indicted or referred for further, regulatory actions or processes. I think that it is part of the recommendations and we are bound by them at this point because the minister says he's written to the various bodies to ensure that these processes happen. So whatever it is, it will happen. But we need to distinguish where we are now from potentially what is to come. At this point, none of these 7 professionals is guilty. Let's be factual about it.
But they are culpable.
No. Our constitution says you are presumed innocent until proven guilty.
But when it comes to negligence,
no.
The committee's work.
Good. So go on. The committee's work what?
Said they were negligent.
And that is where I have a problem with the committee's work. If you look at the concept of medical negligence, it falls under the law of torts. The committee had no moral as well as legal status to talk about medical negligence. You were a fact-finding committee. What you needed to do was to find the facts, and as has been done, the next steps would then kick off.
Were they heard?
Who
the
heard?
professionals, were they heard?
Being heard under an inquisitorial exercise is not akin to the judicial exercise. The judicial exercise proper is now going to start from the quasi-judicial processes at the Medical and Dental Council. These professionals will have the right to then appear, put their cases, be heard. They can go with their lawyers and what have you. At the end of the exercise, a decision will be made. That decision will be backed by law because the act that establishes the Medical and Dental Council, at the E51, talks about the fact that the penal and disciplinary committees of the MDC will have to go take them through the processes. And when a decision is made, the law has even spelled out some of the things that can happen. You could be suspended, your license could be revoked, you could be fined.
After you go through that process?
Yes.
So the ACOSA committee was useless?
It wasn't useless. It wasn't useless, but their conclusions on medical negligence is problematic. You have the right to talk about the things you have found, but you don't conclude because you are not a judge or you didn't have quasi-judicial powers.
But if they heard from 2 parties, can they make a
So let me ask you, so then why are they referring them to regulatory bodies to do what? If they had the powers to make those determinations, why didn't they, in quote, punish them as well? So let's get the processes properly separated from each other. You see, the committee report, when you read the report, it doesn't talk about negligence. However, it was at the presentation of the document to the minister, the comments by my good friend and my lecturer, the good old Professor Jimabido Akusa, a very good, medical doctor, pathologist, Professor Azad, no doubt about him. He trained me, so I have no doubt. But the committee's report, and he is not the committee, the committee's report, the commentaries that happened on the day of presentation, that spoke about blankets, negligence and medical negligence, and those are the problematic areas. And that has given opportunity to people to cyberbully these professionals.
But was he not simply calling a spade by its name?
No, you cannot call a spade by its... Look, listen. The medical negligence, as we speak about, is a tort. Under the law of torts, in our own jurisdiction called Ghana, the famous Edwisa AGA, as he then was, in the case of Alassane Kotokoli and Moro Hauser, stated or defined medical negligence. He said, in its true sense, medical negligence is not coterminous with a heedless or a careless act, whether in omission or commission. It rather connotes the complex concept of a duty of care, a breach of that duty, and the resultant damage or injury. Within these things, duty of care owed by hospitals to clients
and doctors.
It's a matter of fact.
We know it.
It's Trice law, so nobody will.
And the breach we've also seen.
Hold on. The breach, the processes within i.e. causation and whether there was direct injury, proximity, and all those bits, would then be interrogated by the judicial body or the quasi-judicial body to determine medical negligence. In fact, if you look at it strictly, it lies within the ambient of the court. At the professional level, the regulatory level, it is professional malpractice. They are going to look at what you did and weigh it against what the prudent and the reasonable medical doctor will do. And that is why most of the time when proceedings happen at the regulatory level, we talk about professional misconduct or infamous conduct in the professional respect.
We don't say medical negligence.
Usually you don't see those. So we need to let people understand what is happening. Because you see, once the committee spoke about negligence at the
report stage,
it's not contained in the report itself. I haven't seen that. However, the pronouncement, the commentaries around it brought that into the picture. If they go through the process and for some reason they are absorbed of blame, or the threshold as said by the law court or as said by even the judicial body does not find them guilty, what will you have done? And how do you come back to, in quote, undo? So those are some of the lingering problems with them.
So does it mean then that the locus and capacity of the ACOSA committee was overreached to an extent by his commentary, even if it's not contained in the full report?
Exactly. And that one has to be said clearly. That is the truth.
And that has harmed your people?
To an extent, it put them in a very difficult situation now, because now they are being cyberbullied. Some say, yes, now we have the corporates, we have that. But the committee itself says, refer them to the appropriate legal agency of the state, the Medical and Dental Council or the Nurses and Midwifery Council, for them to now go through the process.
But the pronouncement and the announcement by the chairman, to a large extent, brings closure to the family, and the family has said that. And in the law of equity, this man has suffered, his family has suffered. They have to have something to hold on to. And for them, this is something tangible they can hold on to. You want to rob that from them?
No. Let me make something clear. I don't have a problem with the general recommendations, the findings, and all of it from ACOSA's committee. I think it was, good job to a large extent, because it has actually identified all the problems we are talking about. All the problems that we've spoken about over the last 20 years, 15 years, what have you. So all of them are properly documented and they are in our official records. And for me, that is good. So there's no problem. What I'm saying is that it's the commentaries that sought to portray the professionals as though for now, legally, they have been found guilty of medical negligence or professional misconduct. That is what I am talking about.
Is it the phrasing you have a problem with, or the fact that their names were mentioned? Should their names have been omitted?
You see, both ways. If the persons have now been referred to go through the formal processes, that is here to determine whether they are guilty or not. If you make commentaries that suggest that they are already guilty by making it those categorical statements that medical negligence.
They failed the patient.
Not just failed the patient. The words used was medical negligence. Yes. And then they, technically speaking, are now going to go through the process that will rather confirm what you said or potentially even say, no, they did not. So it would have been better for those comments not to have been part of the narrative. Do your referral, let them go through the processes, and then whatever the final outcomes are, we'll know that, yes, A, B, C were probably found guilty or otherwise. Whatever the decision is, the law says they also have a right to appeal their decision at the High Court. So proceedings at the Medical and Dental Council in itself is not a finality.
Okay.
This whole document, for me, has also given an opportunity for us as individuals of the state to also start suing the state itself, because the facts have been unearthed. The state is also culpable. The facts are clear in the document. It will be up to the late Charles Emisa's family to decide whether they want to go on that route for some compensation or otherwise. That one
So for you, if there will be a suit, as a lawyer, the suit should be in the name of the Republic, not against the doctors who have been mentioned.
No, you see, for me as a lawyer, if I'm going to sue somebody, I won't go after a man of straw. So whatever it is, the state will be one of my...
Vicariously.
Yes, because for so long this has happened and we've never taken proper steps to help remedy some of these things. But now, there's a proper document
that you can rely on.
You can rely on.
Do you get a sense...
You see, Akosa's committee was a fact-finding committee. Let's make that clear. It was not one that was to pronounce, in quotes, guilt or otherwise.
And we know what...
The bodies that can pronounce the guilt or otherwise properly are the ones that the committee said these persons should be referred to.
Do you think that his public commentary would prejudice whatever the dental and medical and dental council and the nurses and midwifery council would also be doing?
Well, it may or may not. You see, I mean, they are yet to go through the process. Probably if I am sitting there, I will be oblivious to everything that I have heard from the outside. Judges, that is how they behave. So I cannot say categorically. But others have also raised a certain issue, that they wish the good professor probably had restrained himself or recused himself from even the committee. Looking at the nature of what was to come, potentially some of these doctors could end up at MDC, as has happened. And he's also the chairman of the Medical and Dental Council.
Oh, he's...
Yes. Yes, somebody may say that the entire processes might not involve him directly because he might not sit on a panel or whatever. But at the end of the day, for your license to be suspended, it is not the registrar who will take the decision. It is the council chaired by him. So if the findings are not in tandem with some of the public commentaries, what do we do?
So he's a judge in his own cause.
Maybe one can say that. But for me, those things were just limited to the commentary. That's why I heard those.
Okay.
Looking at the documents so far, I haven't seen those exact words that were used in the commentaries being there. But
reports.
It's problematic.
Okay.
The other side of it is that, for me, we need to look at everything holistically. 7 persons have been indicted and are to go through the regulatory, processes or disciplinary processes at the level of the regulator. That's fine. But if you look at the reports and if you listen to Prof. Akosa, there were a few things that were said about the ambulance service. That for me is also troubling. And for some reason, we have skipped it. The good professor says that the ambulance service, the staff, in quotes, they didn't do their work effectively. He talks about the fact that in the ambulance, if they had secured hemostasis, securing of hemostasis, when we break it down, is what he said, if they had packed properly, compression, all of it, to stop the bleeding, and also even administered IV fluids. This patient most likely may have been with that in spite of all the... You also talk about the fact that the ambulance itself, the equipment in there were in a bad state. You talk about the fact that documentation and handover and all of it were not properly done. So clearly the ambulance service and the EM team should also have questions to answer. But it looks like they have been left off the hook, at least from what I have come to.
Because they did 2 hours of
It's not 2 hours, let me tell you. Even if it's 10 hours, okay? Even if it's 30 minutes, even if it's 100 minutes or whatever it is. Look, in trauma management, what happens within the first 10 to 30 minutes is very crucial. And they were with you. Throughout the 118 minutes, as said, they were with you. Why didn't you secure the hemostasis? Why didn't you give the IV fluids and all of it? Those are part of your basic training. You see, part of the systemic problems too is this. You can be in the ambulance for hours, and with proper arrangement and proper communication between the EMT staff and the doctors or the professionals, they can actually even guide you to do so many things in the ambulance, assuming your level of training is not even up to that. We had a situation where, as Akosa put it, it was just a transporter. So the very basic gadgets that should enable them communicate with the hospitals. And if you realize their movement, they were just going in the blind. All of these problems, the ambulance service ought to also have something to say. And I think that, I don't know whether it was an omission or maybe at the presentation level, because the document itself may be voluminous, all of it was not covered. But so far, it looks like that area has been left untouched, whilst the professionals who were part of the rescuing activity in terms of making sure Charles is not, in quote, lost, those at the facility level, they seem to have been put into this situation. But one last thing, there is something that has also happened in this whole bit that I think we need to talk about it. The media itself hasn't spoken about it. The authorities haven't heard anybody speak about it. But if you look at the causation, it started with a supposed hit and run rider or driver.
Yes, at Circle.
Where is that person? How come the Ghana Police Service, the MTTU, the road safety people, with all the cameras we have around, even Circle, there are cameras around, why haven't we identified this person who started the chain of causation?
But the chain was broken, so if you were interested
No. Listen, if you are a citizen of the state and you hit somebody and you don't even have the basic human feel, empathy, to even stop, to help rescue or to help get the person to the hospital, or even make a call for the ambulance or something to come, and you run away, you are a criminal. You are a criminally minded person.
The police should go for.
And I'm surprised that nobody is talking about it. And I want the media to also wage a similar war, not only on the professionals, but on the Ghana Police Service and the Road Safety Commission, to tell us where this person is and let him be put before the courts as well. The Attorney General also has a role. You see, if we really want to bring closure and make sure that things are done properly, we should look at both sides of the equation. Let me just ask you a basic question. Why is that person who caused the problem not interested, or all of us not being interested in who this person is, and let him also face the rigors of the law?
Because when the person did what they did, they have run away.
Okay.
And then the people around carried this person to the hospital. So now we blame the doctor who could have saved the person.
I'm not saying the doctor.
Because even if he had stopped, he would have carried the patient to the hospital anyway.
Yes.
Which has ultimately been done. And that's why I'm saying that the causation got broken somewhere.
No, see, let me tell you something. You see, I also keep telling people that, you know, it's unfortunate we've lost a brother. So sometimes when you are discussing some of these things, we also need to be a bit sensitive. But it's possible he could have been alive. You know why? If this hit and run rider or driver had picked him up, maybe they could have even ended up in a private hospital or a different facility, and only God knows what may have happened. It's also a possibility. But all I'm saying is that, you see, the carnage on our roads is just one too many.
Okay.
And the police service should also be held accountable. By now, a committee should also be set up to investigate the police service and the National Road Safety Commission or Authority.
And let's use the cameras as Circle to see.
You know, because, you see, it is all part of the process. If the medical team can be subjected to the process, the agencies of state responsible for finding this person and prosecuting him, because that will also be a deterrent for others not to repeat the same thing.
Doc, before you joined us, there was a conversation around the no-bed syndrome.
Yes.
And how you doctors miraculously find beds to treat people when a phone call comes through from a higher authority. Why does that happen? How is that you say there's no bed in this case, and then when someone calls a minister and a minister calls you, you might miraculously conjure a bed like Onfanoche?
Okay, so let me tell you something. Personally, whether it's the president, the vice president, the minister, my brother, chairman, if you call me, I'll tell you the fact as it exists. And I'll tell you that you can come and see things for yourself. If there is a bed, at that point, personally, I'm not ill.
They'll transfer you to the north if you say that.
They should transfer me to the north. That is what they believe in. They say punishment for telling the truth is to go to the north. They should. If that is what it is, they should. We'll tell the truth as it is. We all have different ways of. Yeah, but that is what the minister, Linda Oklu, has told us. Unless the media, you also lie to us.
No, but anyway, she spoke, it was her own
I said, unless you lie to us. That's what she's told us. I'm putting the caveat because you reported.
No, we
in this day of AI,
she herself said the
maybe
video.
This day of AI, you guys did
No,
something.
she didn't say the video.
You know, in this country, when anything comes communication, they will tell you how she has apologized. Yes. So it means she's accepted. So let's move on. Let's move on. Let's put it to rest. So, see, we need to let things work the natural way. If there are no bets, no bets. But you see, this no bet syndrome, it's a little complex at times. In the emergency room, if let's say there are 20 beds, some may have been designated orange, red, you know, that color coding we use. It's all to show you that this is severe than
the
this.
Exit plan.
It helps with, you know, remember when we built the infectious disease thing, we had to separate, you know, high dependency, ICU, and those things. So they are levels. So for example, if you come in and the whole of the emergency room is full, all the beds are totally occupied, the chairs that we put around, even though it is not the best practice, if those are also fully occupied, let's say you need to be on a ventilator, there's no ventilator available. If the health system is working properly, we should be able to refer you to another facility. Referral is part of the medical processes. I remember when we were in school, one of our professors said to us that if you're a doctor and you know the point at which to refer, you've done 80% of the job.
Okay.
So that business of referral and all of it can happen. When you come in and it's an emergency, we cannot carry you to the pediatric ward if you're an adult, because the setup that is needed to take care of you might not, it will not be there. So there may be a bed at, let's say, the pediatric end as part of the 2,000 bed capacity.
Or a female ward, and you are a male.
If you are doing things properly, you know, so there are dynamics. It's just that sometimes we are not truthful to ourselves as a system. They will tell you that even where it's full, we shouldn't even announce or communicate. But ideally, if systems were working, we can communicate within the health facility arrangement across the sector,
and
not
ambulance.
necessarily so that we can always have overflows being sent to some specific places. We can even send doctors, assuming the skill is not there, to those facilities on temporary basis just to help deal with the issues, and then things are stabilized. It is that dysfunctional system we have created for a long time that seems to be giving us all this no bed and what have you. And the last bit is that as a state, we have refused to do the proper investments that we need. See, if you take the ECOWAS region, ECOWAS itself has a protocol that says about 15% minimum of your national budget should be dedicated to healthcare. Ask whether Ghana we have ever been able to attain that. So the underinvestments over the period, it's all part of it. If you take Accra and its environs, the population in Accra and its environs, Kaswa, Tema, you know, it's the most heavily or densely populated area in Ghana. From the west towards Accra, you won't find any proper emergency facilities. From Kaswa all the way. From the north end, i.e. from Isao, you won't find anything. You look at Achimota Hospital, the one within Achimota, so look at it. Then, if you look at the eastern side,
Tema General Hospital.
What is the state of China? So
horrible.
The population is also one of the problems we also need to address. We cannot stop people from coming, but the infrastructure will have to be commensurate with it. And then the human resource itself, we also need to do better.
I've just been given information by my producers that the sister to the late Charles Emisa has said that the police have said that the cameras could not capture the accident scene because it was obstructed by a tree.
So then you see, this is why they should even be investigated more. Why should you sit down for a tree to obstruct it till today? If you are monitoring your cameras properly, you would have seen that this tree has obstructed and you would have done the needful. You see, it is quick for people to think that it's only the medical profession that should suffer. See, let me also ask.
So imagine the number of cameras we have in town.
Let me also ask, God forbid, if it was one of the high-ranking members of government or the society, or even the police service, Are they telling us that they couldn't have found that person? One too often, or many times, we hear that when it's about the police, they are quick to find the suspects. You know, so these excuses are just not apt.
It's scandalizing, to say the least. This is a big
And
issue.
look, I beg you, now that we've even had this revelation, I think, City, you should take this charge. Let's get the police and the Road Safety Commission, including the AGs, to give us answers for this particular situation.
Okay, this is a big
the
issue.
next time it will be you, they will tell you the camera crowd was covered by somebody's towel or something. I mean, what kind of excuse is that?
It's unbelievable. But
obstructed by a tree.
By a tree, so the leaves grew.
No, you see, were they not watching their cameras?
No, it means the cameras that we have in the city, we can't even trust that they can be useful to us. The
Don't
next
say
time
that.
they'll say there are no batteries in there. Maybe there's. I mean, it's sad to hear. I mean, I heard the regional minister, for instance, say. I heard the regional minister say that the street lights that they are currently installing are being stolen, and they don't know what to do because they are doing this whole street lighting agenda.
Arrest the thieves.
He said that they got
Prosecute them.
she said they got videos and that the system had video, but they can't find the individuals. The police are moving through the town showing the videos to the people. They can't catch anybody. I heard her saying this. I was shocked. Let me come back. Let's conclude this conversation on the infrastructure. So we talked about infrastructure. And we are told that there's a hospital that is sitting at the Wager area, which hospital we are not operationalizing. It reminds me of what happened with UGMC. The hospital was there. They said it was complete, but they will not use it. I don't know why. We have to have a conversation like that. So in concluding on this conversation, I want us to, and I'll start from you now, because I'll come around. What's wrong with the Wager hospital? And why is it that we are not having difficulties operationalizing it? Unless you have something else you want to conclude on this, Charles.
No, I just wanted to, I'm glad that Dr. Youngson is here, and I think it ties in to what some of the conversation that was going on prior to our arrival, that we're not trying to say that individual culpability should not be considered in this case.
Exactly.
We are trying to say that individual culpability is not the reason why the healthcare or the emergency care system is the state it's in. That's all we're trying to say. And that in looking at long-term solutions, I walked you through, again, the stats from the Harmonized Health Facility Assessment done by the Ministry, WHO, and Ghana Health Service. That assessment was done 2 years after COVID, around the time where the Agenda 111 hospitals were kicking off. So we knew the status of emergency care in the country at the time. And if 2 years after the biggest global health emergency in 100 years, where we knew we had oxygen issues, we knew we had specialist issues, ICU beds issues. We have a situation, like I said, where in 2023, removing the teaching hospitals, 4% of emergency offering facilities were able to do airway intervention. I mean, sometimes it's hard to explain how ludicrous that is. So we have to be fair to the fact on the ground also, like Dr. Youngson is saying, that there's resourcing, there's financing and all those things, and really be intentional about prioritization. So I'll leave it there for now.
Okay.
On the Wager issue, I only know what's in the public reports, and it seems like it's a question about a contractual issue between the contractor or builder and the government. It appears that it was funded by a World Bank facility, and that World Bank facility had certain stipulations around the way procurement was supposed to be done, especially value for money. And what I've seen in that World Bank report suggests that some of the procurement that was done there, the World Bank themselves flagged it as being, I think that was 3 to 11 times inflated for what was being procured. And I think they quantified a certain particular procurement that was done, that was about 3.8 million in terms of the inflated amount, and flagged that as non-admissible expenses, which meant that money was no longer available to government to use to pay the contractor for the balance of the construction. And it seems like that contractual dispute is really what's playing out in terms of the inability to open it or inability to hand it over. I think in these kind of things, the game is always making sure that it's visible or on a minister's agenda, and then from there, the kind of encouragement to really understand what the need is to open. So the World Bank report specifies that it was, like I said, about $3.8 million that has been more or less defaulted within the facility. But as to whether there's other issues behind why it can be operationalized, those are not necessarily in the public domain, but the understanding is that it has to do with process in putting up the facility. And I think that's something we have to pay attention to.
Okay.
We know that in our healthcare system, sometimes, and it's been said here, that when there's a priority on the table for health, too often there's thinking around what's available around it. And the prioritization of what we invest in and what we do is not always driven by what the actual needs are. So I think it's a big reminder as to why so many of us always talk about the fact that we shouldn't treat health and health policy like it happens in a vacuum. Health policy is a question of politics. Politics is a question of values, and that's what determines how people do prioritization. So if we treat it like it's an abstract thing that we can't solve issues around rational procurement when so many vehicles or models exist to get it done fairer, more cost efficiently, then we're not being candid with ourselves. So for me, I think if there's a conversation to be had, it's how do we have a situation where we are doing procurement funding for a critical national investment and we're seeing inflated prices. We're seeing this is something that is a recurring theme in our health sector development. So why is that happening? What are we doing about it to make it so that we can have rationalized pricing, reasonable standardized procurement, and actual efficiency in the processes that led up to building and opening facilities? So from my understanding, that's what I can say for now.
Duncan, at the time we are complaining that there are no beds, we have beds that have been put up in a very beautiful, and I'm looking at the picture of the hospital, very beautiful, and yet there's a tussle over would we open it or not. Yesterday, I interviewed the PR or the spokesperson of the Ministry of Health, and they said, listen, what they have put out there, it is a fact. The contractor is saying no, they will sue the government. I find it a bit bizarre. I don't know, what do you think?
Well, Sanda, I would say it boils down to priorities as a country. Where do we put our investments, and what sort of investments are we even putting in the first place? Is it just about building hospitals, or you would rather prioritize, like in the energy sector, retooling the backbone? If you have 1,000 hospitals across the country, and as my brother indicated per the statistics, equipment,
they are just mortuaries.
It's woeful. It tells you that you might need to invest a lot more in getting even the existing infrastructure to an appreciable healthcare delivery, standard, such that if anybody is at Dodowa or Kumewu or Bolga,
Dodowa, we have a nice hospital, Shire District Hospital. We are fine.
Lucky.
We are very fine.
But as to whether we'll continue to retool to improve healthcare delivery is another thing. Or again, we would go for the expansionism theory that says that let's just build more hospitals. So if you have $100 million limit, let's say, and you could use that to retool, let's say, 100 hospitals, would you make a decision to build one hospital for that amount, whilst you leave the others that you already have bleeding? I mean, because they cannot even provide the basic health care per the statistics I'm getting here. I think that our priorities will have to be well measured. I think that as a country, we would have to put the health of our people first. Sanda, I don't think any of us in this room would dream of waking up tomorrow unwell, or even in the next 1 hour unwell. As and when these things happen to any of us, your first point of contact is a healthcare facility or a medical practitioner that you expect to be able to do something to keep your life, running for a couple of years more. If we don't prioritize this, then it tells you how bad the social fiber that we have is rotten to. Black Stars are soon to go for a World Cup, in June. I had the privilege of seeing something that says that we are probably one of the worst ranked teams. And so there's not much expected of us. But watch, within that small, time frame, the amount of resources that we would dump in there, that will be borne not only by corporate, Ghana, but by the state. And then you come to tussle over $3 million for a hospital facility. I think that the health minister, they should sit with this contractor. I'm sure there were contractual documentation. If they can also do an audit to be sure that value for money is what we are receiving. Sometimes it could just be a simple structure, but whatever has gone into it could be worth the money. So maybe they should do a simple audit, sit in the boardroom, resolve this and ensure that the people in Weija who probably might deserve, that primary health care that this facility offers are not given the wrong end of the stick.
Regardless, the hospital is completed. Let's just open it and use it while we do the legal task.
Sandra, the contractor would need to be paid legally. And I do think that we cannot also go in there as a people or a government and bulldoze. The state would want the law to work, so the state cannot be lawless. Sit, do an audit, go through your contractual obligations or liabilities, and see how best you can resolve this. It should not become something that we even have to discuss a week from now. The people need these facilities. I was happy when UGMC came on. I was probably one of their first patients. Okay. You go in there and you see that something modern has come up.
It makes you even feel well.
You feel well, as opposed to all of us, congregating at Korle Bu, because it was probably Korle Bu and Rage and then 1937, everything. So if you expand healthcare, it works. But I think that our priorities should be set right. If we need to build 10 or 20 every single year, don't do so at the expense of retooling of the existing ones, because you cannot just continue building whilst you cannot resource the ones that are already available, that people know. The new one, if it comes up, it could take you 2-3 years for even the people within the catchment zone to even be aware that this new hospital is here. Most of them will still come to Korle Bu. You watch. Until such a time that, word of mouth, and recommendations come in that, the one here is equally as good. So you don't need to travel all the way to Korle Bu to go and choke the space. Yeah. So whatever can be done, I think that Akando should be able to resolve this matter before we congregate again next week. Otherwise, we'll ask questions and critical ones for that matter.
Honorable Aban, the hospital is on the way to your constituency, and I think you have done some research on the hospital. Earlier when you were making your submission, it seems like you had a lot of shots. Who are you firing? The government, the contractor?
No, I think he was referring to the Kasua.
The Weija one.
We've discussed that one. I've discussed that one with him. So I don't want that one to be public.
Okay.
But what all this tussle brings to sharp focus: public sector procurement and the corruption underlying it. I think that's what it is.
The oiling of the system.
Because you see, if the few bits and pieces of information out there is what we are going to rely on, it appears to me that the World Bank thinks that certain aspects of the procurement is heavily inflated, right? So they do their own audits and think that no, this we have to disallow it. We would not pay this. And because it is part of the cost buildup, the question is who takes responsibility. So it means then that the government will have to then look for that amount of money for the contractor. The contractor also knows that, hey, I'm dealing with the government. If I let go the keys, it is going to take me 100 years or something like that for me to get my money. So let me get the people behind me. Let them put pressure on the government, and government will then have to pay me, and then I'll give it to them. That's what it is. But we should not just sweep that whole canker under the carpet in the discussion of this matter. We must bring it up. Why is it that when I'm going to buy, let's say, this iPad as an individual, let's say it will cost me 2,000 Ghana cedis. But when somebody is going to buy it for government, and even when the person, from the little economics that we learned, the person is going to even enjoy economies of scale because he's going to even buy more, right? And we expect that he is going to get it at much lesser price. He rather comes and it is twice the amount. Why?
Because we pay consultants, we pay tax, we have to sort out people and agents and fees and all.
That's all the more reason why we must clear all these people off the path in the procurement process.
And it will take forever for the process to even go through.
Yes, because somebody will have to drink some soup on it. We must face it. We must face it. But you see, anytime that I talk about these things, I just don't end it at that level. You have to trickle it down to the ordinary person and the pressure he puts on the politician, and how the politician is looking for innovative ways to make money outside so that he will be able to still satisfy his constituents and remain relevant and nice to them so that they can vote him back to power.
So you lose the election.
Exactly. I've suffered it and I know what I'm talking about. Right? So we must start talking about that. All these public sector procurement, if I say chop, right? It's all born out, of course, you still have people who are greedy anyway, even though they are not under any pressure, they are still greedy, they will do it. But this kind of foolish expectation that you get into politics or you get into government and within 4 years, you must be very rich and very comfortable, and even if you don't go again, you must be fine. Because I'm talking about something that somebody said to my junior about me. This my junior goes to court, right? Announces that he's holding my brief in a case. He is done, and a fellow lawyer asked my colleague, "Oh, you mentioned Mr. Haban's name. Is it the former deputy minister?" He said, "Oh yes, I'm working in his law firm." Then the guy said, where he got to, he has come back and still doing practice with us. Yes.
Just say you should have been enjoying some.
That is the thinking of a lawyer.
So when you retire, don't come. You should be above.
At this time, I should have had some very good chests with money in there. I should be comfortable. I should not find myself.
You should be playing golf.
He should leave the space for us.
Yes.
I should not find myself going back to court.
Yeah.
God bless that. I mean, I don't know. It's bad. It's bad. That's our thinking. And so, once you are in government, that expectation is there. That pressure is there. So sometimes you see, this is 2,000, and before you realize, somebody is bringing it 6,000 Ghana cedis, and government is going to pay for it because somebody is sitting quietly waiting for his 10%.
Kickback.
Sometimes it's even kick forward because you have to get it before
they even sign it. Money for hand back in the ground.
So it's a whole lot of things, right? So whatever has happened with this hospital thing, right? We must look at it. We must start thinking about how come government projects are so expensive.
Let me ask you this question. You have served in the executive.
Yes.
You have also served in the legislature.
Yes.
The parliamentarians are supposed to hold the executive accountable. We have laws that prevent these things from happening. So how can we still see them?
Please don't go there. Please don't go there. Don't go there. Don't go there. Don't go there. So long as we have our constitutional architecture the way it is, where every MP is trying to look good in the eyes of the executive so that he can get an appointment.
No accountability.
Forget about it. And I can assure you, many of those who do not even scrutinize the documents, it is coming from our government. Look, and when the time comes, let's say here, and let's go on. He is in parliament and he knows that. Right? And those of you who will scrutinize it and who will apply your energies, everything to parliamentary work, they will show you the exit the next time. Because you may not even get the time to go to your constituency and all that.
You are busy working in Accra, you think you are working for government, then someone is undermining your constituency.
Exactly. I had a very bitter experience. We were working on, I think, the either the OSP Act or the Companies Act.
Okay.
We had been assembled at, I think it was the Companies Act. We had been assembled at Kofodia. We were working on it. And because of
committee
some,
meeting.
Yes, and because of some little education I had on my master's, on some of these things, virtually I was leading in the discussions.
Company law experts.
Yes, I was leading in that discussions with support from, okay, we don't know, we don't need those names.
Yes.
Meanwhile, there was some funeral in my constituency, and my party people felt that, look, as for this funeral, no matter what, you must come.
The Okoboy situation.
Right? You must come so that they see you. Right? Meanwhile, I was working for Ghana. Right? So I told my chairman, the chairman of the committee, that, you know what, I have to dash to Gomua and come back. On a Saturday like this, I nearly got into a ditch at Suhum.
From Koforidua.
Went to Gomua, spent only 30 minutes and came back. So this thing, we must not just look at it just at that level. Let's also look at the pressures on the politicians. If you are going into politics and you see it to be transactional, that you are going there to use your position to make money and all that, they will not care, because they will get it and come and sprinkle something on you. But if you're going there to serve the people, forget it. I'm done.
It's difficult.
Yes.
Sounds very sad. This is a very bleak image that has been painted for us. Dr. Nawani, you are inside there now. They've kicked him out. And it could be the kicking out either from the national level or from the local level, but still there's
it depends on, if you're very objective, you may not even get it well with your own party.
Yes. If you like, try. Dr. Nawani.
Yes.
The Weija Hospital problem.
Litigation.
Litigation.
Yes, and the lawyers will tell you.
It's not corruption. It's not corruption.
There's the corrupt aspects. This procurement they are talking about, it took place in 2024. So Minister Kando inherited it. And in view of that, no, I'm saying that he inherited it. And so in view of that, there have been investigations going on. But apart from that, the issue has to do with the contractor, just like they said. And the contractor is saying that unless they pay him his money, yes, he's not ready to this thing. And well, looking at the situation, you can't rush over it. No, there's nothing. Look, I had a road contract in my constituency. The same thing I faced, just to list it as a road that is supposed to be constructed, reconstructed or done. They are giving it to a contractor, and so the contractor's name was there, and so he was not ready to allow me to relist it for work to be done. Meanwhile, he was not ready to come and do the work.
So it becomes a Konongo Kaya situation.
Very good. He was not ready to come and do the work because
he's put some money inside,
and
that money is not
something small, yes, on it. Until they were, it took almost 1 year for them to get the contractor to write officially that he's no more interested before I was allowed to list that road as a road that needs to be worked on. The same thing is what is happening now. And the minister, we are in government. We must obey the law. It is not that easy to just, I know that there were demonstrations, etc., but we still need to sit down with this contractor, like someone said, and see whether he will allow some form of arrangement to be put in place. Because $3.8 million is not something that is too small to be taken from the Ministry of Health. All this amount.
But if it's a priority, we'll find the money for it.
You can write to the Ministry of Finance, but remember the whole Ghana is writing to the Ministry of Finance. So even though yours is 3.8 and you think that it is small, with the amount of letters that the Ministry of Finance have.
Yeah, but if the government prioritizes health, child health care.
So everybody thinks that his area is very important. You see, and that is why sometimes you see the doctors and those working at the hospital, when they want to demonstrate or something, it appears that they want to say that health is the most important thing. But the same thing teachers will say, the same thing the road contractor. Everybody, this is how it goes. The fishermen, if you meet them and you are discussing issues about what is important, and of course that is how nature is. I mean, the whole this thing is everybody, his profession and everything.
It's important to them.
It's important. I'm waiting for the day journalists will go on strike and we'll see what is going to happen.
No, they beat us already. So what's the worst that can happen?
Yes. And so the amount of money before the finance minister to approve is not small. Yes, for the Minister of Health, I believe he will do his work. Appeal to the Minister of Finance to do something about it. But the response has to come. Okay. It's not something that they can take out of their budget to solve this problem. But I'm hoping that we'll make a headway. Okay. Yes.
Dr. Jansen, you
and
understand?
let me use this opportunity. You see, we are sitting down here talking of the lack of beds, Let's go and pay $3.8 million and get more beds into the system. But as we speak, the faith-based hospitals, I mean the mission hospitals, the CHAC ones, in Ashanti and Central, some of them are being disconnected from the national grid. Because
as in electricity?
Electricity.
Because they didn't pay their bills?
Exactly, because they owe. The Minister of Health has written to his colleague, the Minister of Energy, saying that, please, these hospitals are part of some group of hospitals, the Ghana Health Service hospitals and the rest, and that under no circumstances should they be disconnected. We should always dialogue. The Minister of Energy has replied, stating a decision that has been taken in cabinet that, yes, those Ghana Health Service hospitals and then the mission hospitals should never be disconnected. And yet, there are people sitting there at some points in the regions, in the districts, going around disconnecting.
But if the minister gives directive, that cannot be, I'm not sure, that would happen. If it says they cannot be defied.
Exactly, but it is being defied. I have letters to that effect, that the Minister of Energy has written to reply to the Minister of Health on this his demand, and yet it is going on. And we will come back here and be complaining. Let's put on this hospital to increase the number of beds in the country. Meanwhile, we are disconnected.
But they should also pay their bills.
So some hospitals.
They collect money. It's not as if
they collect money, but when there are economic rates. Remember that these faith-based hospitals operate in the hinterlands, the small
but still,
small
they
towns.
still collect money. It's
they
not
collect money, but they are not collecting the amount of money that they should charge.
They are not doing realistic charges.
They are not doing realistic charges.
So there's a lot of subsidy.
For Apam Catholic Hospital.
Yes.
You see,
a lot
of road traffic accidents occur there. A lot of patients are taken there. The church uses its small resources to keep the place running. Take care of these patients. Sometimes they don't have anything to pay back. I think government must also look at some of these things, especially those on the highways.
Okay, all right.
Yeah.
Dr. Jansen.
So let us appeal to the ECG.
No, we can't appeal. If the Minister for Energy has spoken, why would we appeal to ECG again?
They are still doing it.
I don't even understand how this is going to work. If Minister for Energy says don't cut off,
let's tell them
ECG MD is under Minister for Energy. Anyway, we need to go, gentlemen, but I just want to get a quick on Dr. Jansen on wager and also this thing that you people are fighting the lab people. You want to go and the people are lab people. They want to run their lab. Use doctors say you are going on strike at Kolebu. And your reason is that you want to take over their labs. Is this a reason to go on strike?
This has been there for a very long time. When I was there, that turf war was there.
I can't understand this. I can't think that.
Yes, I let the medical association.
To say you want to take over the labs?
No, it's not like that. You see, So let's do Weja quickly.
I have just 4 minutes before we leave here. So
Weja, I have seen the facility myself. You know, it is not just an ordinary hospital. It is a children's specialist hospital, or a specialist children's hospital. If you look at Accra and its environs, it is the biggest you can have now. Korle Bu has the biggest children's block, you know. But in terms
how about
of
Louis? We have Louis Mario.
if you know, there's a very small place.
Okay.
The Princess Marie Louis, the children's hospital, as we call it.
Was a medical
It's a small place. So this one is actually to serve the needs of practically all children in Ghana, not just that constituency. Because it's not just a normal children's hospital, but it's a specialized one. You see, practically we can look at everybody from day 1 all the way to age 13. In the medical setup, usually around 13 years is the cutoff for the children's block. Sometimes even 14 years, 15, depending on what it is, we can keep some of them, you know, but practically 1 to 13. So you cast your eye around Accra. Do you see any specialist children's hospital? Princess Marie Louis. So this is a critical thing that we should not allow to go to waste because of contractual and procurement issues. It's not even just about paying money. I think that what the state should do quickly is to go into some legally binding arrangement with the contractor on the way forward. And that same agreement should allow government to start operating. Because you can see them from the pictures.
Yeah, it looks
well established, well equipped.
Yeah.
There are specialists who were waiting to even go and practice there. And this will add a lot to our healthcare delivery system, especially for children, because we don't have a lot of specialized places for children in this country. So for me, we should do the needful, go into whatever arrangement we have to go into.
Start operationalizing
and make sure and then when the matters are resolved finally, we can actually go back and pay whatever we have to pay. If we have to take from the contractor, we'll take. But within the period, if things are also being done properly, this same facility, aside saving the lives of children, probably will also even generate some money that can also help pay for that 3.4 or whatever million, assuming without admitting that that is even the figure. So we should prioritize health. Look, every sector is important, but as we say, the health of the nation is the wealth of the nation. And here we are talking about the next generation that is actually going to sustain the country. You can see how equipped it is. You won't find this sort of level in most hospitals we have. If we don't take care, this will keep going. By the time we go, the warranty periods for the equipment are over, the service agreements are over, the equipment have even deteriorated because of, they will tell you the sea breeze and all kinds of things. And you know, they are very also close to the coast. And it sits on a high. So a lot of things could corrode in. Let's just say that, look, we have built it. It is well, let's commission it. Let's have some arrangement with the contractor, a legally binding one, so that if government doesn't pay, if they have to go and sell the presidency or the Ministry of Health or whatever, they can go and sell.
The national security comes for you.
No, I'm saying that. I'm just it's hypothetical.
You mentioned when you go and sell the Ministry of Health, you say that.
Any ministry, any government asset. It's basically it's government asset. If it's Parliament House, chairman is here, they will sell it. Then we move on. It's for the state, and the state has defaulted, assuming that is the case. If it's the contractor who also has to get the something, the state should be bold to take from them. But in the process, let's not allow the kids to suffer. And the community has started protesting. Sooner than later, they will tell you that it is politics. But the truth is that they need a service that the facility is supposed to. Why did we build it? We had done some studies. He even gave some of the bits that showed that we needed such facilities. And that is why we committed to building it. If you go there, this building is way better, well equipped than the rest of the hospital. You know, it's the Gan West.
The Gan East.
No, Gan West.
You mean the district?
Gan West.
Yes.
Municipal hospital. This building sits on the premises.
So it's like the infectious disease things at Ghanaians Hospital, so something like that.
This thing, this structure we are seeing,
it's a side project.
Not a side project. It's a project, but what I'm saying is that this facility, as it sits here now, is way bigger, well equipped than the rest of the main hospital.
Okay.
You get it? And it will free a lot of space for the community. And you see, there are a lot of things that we also not take into consideration. I sit in Korle Bu, for example, and people come all the way from Kaswa beyond, and they come all the way to Korle Bu. The children's block is choked and all of it. If this facility is working, from Kaswa, from wherever, you get to Makati Hill, at least it saves you. I've seen people with asthma kids. They bring them all the way. And asthma you can pass in no time. So these are all strategic bits. It's also by the highway. If there's anything, some interventions could happen, depending on who is involved and all of it. So please, let's put our act together. Let's solve the issues with some alacrity, and I think we should be fine.
Okay.
On the medical doctors,
unfortunately, my time is
okay. So
my time is right now. Let's leave it here, gentlemen. Thank you so much. It's been great having you this morning.
I wanted to add that the hospitals themselves should move towards solar also.
Yes.
So
it's
that
also part of it.
instead of waiting on Energy Ministry to be cutting bills for you.
Thank you
Get
for
the solar panels.
I was going to do.
Honorable Alexander Aban, thank you so much for joining us. Duncan Amwa, thank you so much. Dr. Nawani, thank you. Nawani. What does it mean? What does Nawani mean?
Nawani was like a nickname of a development-oriented chief.
Oh, okay.
The chief is Sabrani. So they call his name Sapanawan.
Oh, okay.
Sapanawan.
Okay. So that's what you are.
Yes.
Okay. Nana Kofi Nkwachi, thank you for joining us. And Dr. Justice Youngson, thank you so much. My name is Umaru Sandamado. This has been The Big Issue. We'll return next week with more. Thank you so much for being with us.